Good afternoon, or no, not yet. Start again. Good morning, everyone. Welcome to the Senate Interim Committee on Healthcare. I'm delighted to be here. I love all you guys, and and we're going to open an informational hearing on Multnomah County Mental Health System Analysis Overview and Recommendation.
Morning.
Good morning. Like 4 days. Good morning, Chair Monis Anderson and Vice Chair DeBoer and members of the committee. Thank you so much for providing us today with the opportunity to present this morning. My name is Sharon Myron. I am a Multnomah County Commissioner. I am also a practicing emergency physician. And in that role, I'm acutely aware of how our behavioral health system functions. Too often, people fall through the cracks in our systems of care and end up in crisis, often boarding in our emergency departments for days and weeks and even months because there's nowhere for them to go. As a county commissioner, I'm working to improve the system of care at the policy level. My co-presenter, Dr. Rachel Solotaroff, and I will be giving you a brief overview of the Mental Health System Analysis Report and research process that Multnomah County underwent this past year, and we'll discuss in particular some of the recommendations and actions that we've identified to carry the work forward. But first, I want to give Dr. Solotaroff a chance to introduce herself.
Great, thanks. Good morning, Chair, members of the committee. Thanks so much for having me. My name's Rachel Solotaroff. I'm the CEO of Central City Concern. For those of you who may not be familiar with the organization, we're a broad-based social service organization in Multnomah County and Clackamas County, whose mission is to provide comprehensive solutions to ending homelessness. So to that end, we serve about 11,500 of the most vulnerable members of Multnomah County and provide services inclusive of mental health, addictions, primary care. We also have over 2,000 units of affordable housing and support people in finding employment with over 500 employees in the community. A key part of our organization is that about half of our workforce are individuals who have lived experience of homelessness, of substance use disorder, of serious mental illness. That informs our work. It'll inform the comments I have today. And we have a long and rich history with Multnomah County, from funding through Medicaid and general fund contracts for outreach-based services, residential services, outpatient services, as well as close partnership with many of the agencies. I will say I'm a primary care physician by training with a subspecialty in addiction medicine. And I spent my first 15 years of my career advancing the concept and practice of the patient-centered primary care home in the primary care field. And I can see its enormous benefits in that arena. And I think the time has come to apply that same type of structure, of rigorous standards, and of payment methodology to behavioral health that we've applied in primary care. And that may be one of the linchpins to really advance the behavioral health and mental health system forward.
So by way of some very brief background, about a year ago, Multnomah County contracted with an organization called Human Services Research Institute, or HSRI, to do a deep systems analysis of how mental health services are provided throughout Multnomah County. I wanted to do this study to create a shared understanding of a very complex system toward the aim of pursuing meaningful change. As I'm sure many of you can relate to, the mental health system is a huge, complex, and multifaceted system. It's like a gigantic knot. It is challenging to even know where to begin to pull the first thread to start to unravel that knot and figure out where to direct any effort toward improvements. But we do have to start with that thread. I personally felt that establishing a baseline, this shared understanding of how things look now, would be a natural first step in identifying areas for change. HSRI was tasked with researching and reporting findings on a range of financial, demographic, and qualitative aims related to the way the current system of mental health exists and is experienced by people in Multnomah County. That last part is actually one of the most important principles in the study that HSRI delivered on, centering the voices of people with actual lived experience in this conversation. We don't want to just know what we're delivering or what we think we're delivering, but how people are actually experiencing that in the real world. So HSRI paired qualitative and quantitative data, remaining an objective, expert, third-party validator of findings, many of which aren't new or surprising to people working in this field, but it's really good to have this third-party source sort of confirming and validating what many of us, the advocates, people with lived experience, their supports, have known for years. So they finished their work in July, provided us with a report, and next, what did they find? Overall, the report, and this was really interesting, it found a disconnect, a huge disconnect between the system's aims, so what we think we're providing, and how the system is experienced by people who are using it or their loved ones. And this disconnect is actually at the root of the key findings, and resolving it is at the root of the report's recommendations. So the report makes 3 priority recommendations. The first is to create a shared vision for the mental health system. And I think that's kind of a basic thing, but it actually doesn't exist. And it's not just, sort of a mission statement, something on paper, but it's way more than that. A shared vision suggests something that a broader range of entities and stakeholders actually understand in the same way and are accountable to. Second, the priority is to create a director-level lived experience position in Multnomah County. There are a number of people in the county, in the services we provide, who have lived experience of mental health issues. I include myself as one of those. But the recommendation is really about elevating the value of lived experience by making it the core of someone's job description who's in a leadership role, who actually brings that to the table in making policy decisions. And finally, the third recommendation revolves around understanding how funding flows through the system of mental health care. It's kind of opaque in many ways, and improving data integration and analysis. This can allow the targeting of further system improvements and outcomes, and we actually can't do that work unless we have an understanding of those aspects of the system. So the report forwards these 3 primary priority recommendations, as well as multiple others. And operationalizing some of these recommendations can help provide opportunities for state action, which I will speak to a bit later on. The report also highlighted some important themes that show up, and I just wanted to call out a couple of those. So there are the priority recommendations, then there's just some general themes. The first is workforce. We know that workers across this system are often underpaid and overworked. They're in unbenefited or underbenefited positions. They have high volume, very intense caseloads working on the front line and don't always receive adequate training, supervision, and support in their jobs. And actually, I think Rachel's
I would just jump in here. My concern here specifically is that it affects staff, the staff that have less professional training, such as peer support specialists, qualified mental health assistants, certified alcohol and drug counselors, people who are now managing large caseloads with high complexity, providing a level of service for which they're not trained. And we hear a lot about the use of peer mentors in behavioral health, and that is an excellent idea, but we have to make sure that peers both work at the top of their license as well as within the scope of their license, which involves things that they're wonderful at: engagement, navigation, just providing good common sense. Unless they have a good team wrapped around them, they end up doing more things like case management, counseling, crisis response, which can put themselves and clients at risk. Also, with under-resourcing staff, we find out that we hire many clinicians right out of school. They may have internships or practicums with us, and they gain brass tacks and real-world experience in the safety net environment. We spend 2-3 years investing in their professional development, and then due to lack of benefits and adequate compensation, they then pivot into a more of a commercial healthcare market and leave the safety net understaffed with more professionalized. counselors and clinicians.
So that's the second big theme that we saw, and this was literally like a reflexive reaction when we would ask someone, what do you see as a barrier in the mental health system? They would just say housing automatically. It's like mental health care, housing. And many of the services and interventions we provide are not as effective, or they're entirely ineffective unless someone has a safe place to live at the time they're getting services. And for many people with complex needs, housing is really tricky to get and to keep. The report makes it absolutely clear that we need more supportive housing to improve outcomes. Multnomah County and the City of Portland have jointly committed to creating 2,000 new units of supportive housing by 2028, and we have some really promising things on the horizon, including projects already in the pipeline. As well, opportunities like the Metro Housing Bond can help address the capital side of producing units. But what we really need to do is work aggressively toward identifying how to pay for the services to pair with that housing. So we can get the physical structures. We need the service and operations.
And what we found in an internal study in our own organization is that those supportive services not only improve outcomes around mental health and substance use disorder and improve housing retention, but they also save healthcare costs. So we have a randomized controlled trial to expand and validate this finding, but what we found from our internal data is looking at individuals who get outpatient mental health or behavioral health treatment with supportive housing and compared their costs over 12 months to those patients who got treatment without housing. And those patients who had treatment with housing incurred 1/3 of the total behavioral health cost and 1/3 of the total healthcare cost as those who didn't have housing support. So the opportunity to align the housing services with our investment in healthcare leverages those two investments and gives us a better return.
So two other themes just to very briefly touch on. A third theme relates to addressing the disconnect between mental health and virtually all other systems of care, particularly in substance use disorder. So if someone has a mental illness complicated by anything else, particularly addiction, we call dual diagnosis, but also traumatic brain injury, dementia, chronic physical illness, there's often nowhere for them to go and no services that they can receive. And additionally, one other pervasive issue that was brought up by many in our study was essentially the lack of culturally specific, culturally responsive services throughout our communities.
Just go on. Okay.
So what are we doing with all of this? We're pursuing immediate short-term actions. For example, we're looking internally at Multnomah County at adding a lived experience leadership position at the county. And that's as we are developing these longer-term sort of structural strategies for sorting through, prioritizing, and implementing the recommendations of the report. And part of this is working with the legislature in 2019 to pursue some key policy and funding goals that begin to respond to those recommendations that I outlined. When we set out to do this process with HSRI, we wanted to do it in a way that would lead to action. We didn't want yet another report. As we all know, some of these they sit on shelves, and we have libraries littered with these, and they all are based on good intentions, but we want to take action. And there are three particular legislative concepts or general policy, sort of buckets that Multnomah County will be actively working on. The first is creating and providing a standard of quality, predictable behavioral health care within CCOs. That can actually go toward that first priority recommendation of looking at sort of a consistent standard of care and expectations of what a mental health care system looks like throughout the county and more broadly.
Have you been working, Sharon, have you been working with the Health Policy Board? Because they're coming out with CCO 2.0, working on that, and these concepts, have you been working with them?
We have. We've been connecting with the Oregon Health Authority and the Behavioral Health Department there, and working on some of those policies. And I would have to ask our government relations people if we spoken directly with the Oregon Health Policy.
Because I always want to make sure that it sort of dovetails into what the Health Policy Board is working on too. So we have enough strife among the CCOs in what they want to do also.
Yeah. No,
Okay, thank you.
absolutely. And thank you for that. And we think the HSRI report does also, clearly highlighted disconnects between system aims and service user experience. The report suggested working collaboratively with local, regional, and state stakeholders to strive toward that shared vision, like I said. And we also think that people, providers and consumers alike, should have a more consistent, predictable experience navigating the mental health system and the options within it. We talk a lot about a no wrong door, but the door you enter the system through should not have dramatically different paths or options to offer. So this can help pursue that goal.
I think that this is an opportunity where we can draw upon our success with something like a patient-centered primary care home model. That was built on some foundational concepts that could really move and transform a system. Things like good access, team-based care, population-based care, and each of those standards then had processes and outcomes attached. These were then motivated by payment models such as incentive-based pay or new billing codes that gave the organizations and the delivery systems enough funding to really start to turn that ship. And they were developed in collaboration between payers and providers to support that work. And the funding could go towards things such as infrastructure, data systems, quality improvement support, or new staff roles that would support a transformed model, things like nurse care managers or behavioral health specialists. So again, I don't think we need to think of mental health standards of care as a far-fetched notion. I think we can build upon transformative action that we've done in this state in the last 15 years.
The second area is, so two more areas briefly. The second area is around substance use disorder rate parity. And this is a huge thing. Like ultimately, we do want to get to a point where we can easily invest and provide services for dual diagnosis patients who have both mental health and substance use disorders. That is going to take a while to investigate and implement. But there's something we can do right now. And currently there's a huge disparity in how mental health and substance use disorder services are reimbursed in our state. And HSRI made several recommendations related to care integration, quality and accessibility of care, workforce stabilization, et cetera, that could be responded to in part by bringing substance use disorder rates up to par with reimbursement for mental health services. It's really hard to provide the services when you don't get paid for that. Mm-hmm. And this is a policy change that could help create high-performing integrated behavioral health teams, improve outcomes, and reduce the burden of a substance use disorder driving healthcare costs, which they do. It is not an end-all, but would be a meaningful step toward parity, toward truly recognizing addiction and mental health as chronic conditions that can be identified, treated, and managed. Increasing reimbursement rates would also have the potential to improve pay and working conditions for individuals in this field, which brings us to the third primary area of focus for Multnomah County and from the HSRI report. Mm-hmm.
I would just say, again, as an addictions medicine clinician, it's highly unusual when I meet a patient who has a substance use disorder and doesn't also have a mental health condition. Trauma is almost universal. More common are conditions like anxiety and depression and post-traumatic stress disorder, but often we see serious mental illness, such as schizophrenia and bipolar, presenting in addiction settings as well. And so the absence of having adequately funded mental health support in the addiction sphere really renders the care that we give suboptimal.
And so that final sort of bucket I was talking about is in an area of support for the behavioral health workforce. As we mentioned, employees in behavioral health systems often work with the most vulnerable individuals living with chronic mental health and substance use conditions. The HSRI report confirmed for us the pressing need to provide the training, support, and compensation necessary to educate, recruit, and retain providers who are really the backbone of our system of mental health care. This workforce must have core competencies and training to ensure the most effective evidence-based care is provided, and that these important professionals who choose to work in these often challenging jobs continue the work they do. High turnover contributes to poor continuity of care and can seriously impact the quality of care that consumers receive. The amazing people who do this work day in and day out are some of our most valuable assets in improving the quality and accessibility of care, and we have to make sure they have the support they need so that they will stick around and do this work in the years to come and not leave organizations like Central City Concern, once they've got that training on the ground for a couple of years right out of school and move on into the commercial sector.
And I would just stress here the importance of culturally specific providers in that sphere, particularly around addictions and mental health. The presence of a counselor, a prescriber, a peer who looks like you, who has the same lived experience as you, increases the value of the therapeutic relationship, but also there's whole new clinical modalities that we use for culturally specific programs, and we are really under-resourced, particularly around having communities of color in our behavioral health workforce to serve the need that we have.
When you start implementing this, are you going to have outcome measures? Are you going to set goals that say, okay, after a certain amount of time, this is going to happen among the consumers, less recidivism into treatment, I don't know, whatever measures you would want to come up with?
Absolutely. I mean, that would be one of the, I feel the most important goals of this is to have that consistent, standardized vision of what our system should be so that we can work toward that and have measurable goals for which we can be accountable. I think some of that work now can be happening in tandem as we implement the recommendations from the report. Some of what those outcomes ideally will be identified in the process of as we are figuring out how to prioritize and implement some of the recommendations, and what those strategies will be identifying what kinds of outcome measures we want to look at, but that's absolutely key in all of this work.
Yes, Senator Steiner-Herwood.
Thank you, Commissioner Meyer and Dr. Solotaroff. Thank you so much for being here with us. I wonder if you could talk, Chair Monis Anderson asked you about working with the Health Policy Board and the CCO 2.0. One of the biggest challenges we face in revamping how we provide behavioral health services in this state is our old system of the monies being primarily directed to the counties, and that money going to serve not only Medicaid patients, but also some commercial patients as well. And I wonder if you could talk a little bit about your thoughts about how do we move forward with full behavioral health integration into the CCOs, which I think we would all agree is probably a goal to be desired, because we don't want to chop people off at the neck, as I'm fond of saying. But on the same hand, not gutting county mental health systems because of the other kinds of services that they provide. So could you talk a little bit about your thoughts on that issue?
That's something that I would probably call on our government relations people to maybe address. I don't know, obviously, I'm not sure how to answer that question.
You want to phone a friend? I see Mr. Black in the room. Madam Chair, we invite
virtually on board here.
No, I mean, that is...
The one suggestion I would, thank you, Senator, for the question. I don't run the county budget, but one thing I would address is that if we fail to integrate payment mechanisms for behavioral health and physical health, we fail to get a return on investment for those. So to the extent that we're able to say to a given system, your investment in behavioral health will recoup savings on the physical health side. We see less visits to the emergency department, less trips to the intensive care unit for osteomyelitis and endocarditis. I think that we end up, if we continue to silo our funding and silo our interventions, we fail to get the kind of integrated outcomes that occur when you actually can integrate those funding and intervention strategies and then show overall a decreased healthcare cost, particularly on the physical health side. So again, can leave it to Justin to support that, but I think that's
We
one of
don't
the
want to
key
get off
issues.
track. These are good questions, but we've allowed 20 minutes for your presentation, and we're already over. I'm sorry. But there are things, I think we need to have some follow-up on this issue, and maybe we would have you come back. Senator DeBoer.
Thank you, Madam Chair. Just quickly, so thank you for your presentation. I think you have addressed the points that need to be done. The pay equity, everyone in this room is affected by mental health. Our homeless issue, everything drives by that. Senator Knopp and I are on the Student Success Committee, and we've traveled all over the state. What we want to do is prevent future problems, and specifically school shootings and stuff. So I'm really pushing for OHA and DHS to provide mental health services to every school within the state and nursing, and take that away from educators so that we can address the problems before they happen. And you brought up everything, so I'd love to talk to you about housing and other things, but it's a problem that's compounding in this state. Yep. And it is fixable. We need to direct the resources, and the savings in the long run are immense. So thank you.
And also, having been around quite a while here, I'm running into my 18th year, by the way. So it's also, we have had so many studies on how the mental health funding works, and no one has been able to come back and report. And who knows if counties are using the money elsewhere or OHA is using the money elsewhere. Yeah. We cannot account for that and how we get around that. If you can solve the problem, that would be great.
All right. Thank you so much.
All right, thank you. All right, Oregon Health Authority. Patrick Allen, Jeremy, Dana, Lillian, Zeke.
We'll do it in waves.
All right.
Thank you, Chair Monis Anderson, members of the committee, Patrick Allen, Director of the Oregon Health Authority. We've got a full show planned for you today. We'll talk a little bit about CCO 2.0. We'll give you an update on public health modernization and spend some time on behavioral health to wrap all of that up. But I thought it would be useful to spend just a minute or two talking about the past year or so. I've been at OHA for about a year now, and we've been doing a lot of work over that period of time. We've spent months on CCO 2.0. You're going to hear a report about that today. We've done a lot of internal work in the agency to try to kind of get to a place where we can be here today really talking about healthcare as opposed to all kinds of issues that are around agency management and those kinds of things. We've significantly, I think, improved transparency in the agency. We've improved our public records request process. All of our records requests now are posted to the internet along with the responses to them, and our response times have improved. We've implemented a performance management system in the agency, so we're now able to give everybody in the agency line of sight visibility to our mission, vision, and values, our outcome areas, our outcome measures, and most importantly to me, the processes that we've set up to deliver those outcomes in the agency and how we're doing on those processes so that we know if we're performing the way that we need to, and we're able to identify problems much earlier and correct them when they're small problems that are easy to correct, rather than waiting till they're big problems that are hard to correct. When you add all that up, the agency really, I think, is able to spend a lot more time focused on its mission around transforming health and healthcare, and less time responding to those kinds of operational issues. And so I think it's been a good year from that standpoint. What I'd like to do is go ahead and turn the mic over to Jeremy Vandeheydt to talk about, together with Zeke Smith, to talk about CCO 2.0 and kind of give you a little bit of a touch base of where we are today in that process and what's upcoming.
Great. Good morning, Chair Modest Anderson, members of the committee. For the record, Jeremy Vandeheydt, Director for Health Policy Analytics within OHA, and I'll let Zeke introduce himself.
Chair Modest Anderson, members of the committee, Zeke Smith, Oregon Health Policy Board Chair, glad to be here.
I know this is a big topic, and we don't have a ton of time this morning, so I'm going to kind of do the Cliff Notes version of a much bigger topic of CCO 2.0, but happy to have any follow-up conversation if we don't get all your questions answered today. This is a pretty busy slide. Really, just all you need to, the takeaway here is we've had a very busy year this year in terms of working on getting clear on the goals of CCO 2.0, and we're sort of nearing the end of the policy development and vision setting process. We started out the year with really casting a pretty wide net in terms of getting feedback on what's working and where do we have challenges within the system, and have been through a public engagement process and through work led by the Oregon Health Policy Board, beginning to narrow that down with really a focus in 4 key areas: improving behavioral health, improving social determinants of health and health equity, moving more from fee-for-service to value-based payments, and continuing to hold down costs. We've had, I think, a pretty significant multi-phase public engagement process throughout the year this year. We started with 4 public forums back in April, and an initial survey of stakeholders in the public, about 1,600 folks responded to. From that, we were able to narrow down a list of policy options in those 4 areas I talked about, and then spent the summer going out and getting more feedback. We did a roadshow of 10 town halls around the state, followed by a Spanish, all Spanish language forum in Woodburn last month, I think it was. We did a second round of survey of sort of broad to public and stakeholders, and then we did a member-specific survey. We had DHM do a random call out to members. I think overall, the feedback we've gotten pretty clearly highlights that those 4 areas I covered are the right 4 areas. Nobody has told us that we're totally off track in those. One area that I think has come up is as we're thinking about better integration of behavioral health, not losing sight of oral health as well. But very strong feedback both from stakeholders and the public forums we've been at, as well as even in our member survey, that those 4 focus areas are really where we need to be focused in terms of CCO 2.0. The other thing that I think is really positive news to share with you all is we had really high satisfaction by OHP and by OHP members in this member survey that we did a couple weeks ago. On the next slide, almost 90% of OHP members were satisfied or very satisfied with their health care and with OHP. They also, there's also strong support for those 4 areas that I outlined. In terms of the overall CCO 2.0 process, so taking a step back, this all sort of started with a listening tour that the Health Policy Board did in 2017. From that, we had identified those 4 areas the governor wanted us to focus on. We started out the year with a retreat that the Health Policy Board did, and then I've spent really this year on the policy, getting clear on the policy goals, knowing that next year would take most of the calendar year to get through the formal procurement process. So the new CCO contract will start in 2020. It will literally take us almost the entire calendar year to get through that actual procurement process. There'll be a request for applications that will go out in January. The Health Policy Board is going to wrap up its final recommendations in October, and we'll spend this fall transitioning to actually drafting the request for applications process. Just a couple of things, we hit on some of this in the spring, but some nuts and bolts on how the procurement will work. So we're going to do a request for applications process, which means that we aren't setting a predetermined number of how many CCOs there will be. We'll be setting criteria, and those that can apply and get over that bar will be awarded a contract. In February, we're anticipating letters of intent being due, so that will give us an early lay of the land before the actual applications are due. We just keep going. we're really, of the various policy options or policy changes that have been recommended, few have sort of completely fallen off the list as bad ideas. I think where we've really spent the last month and a half is moving them into two buckets, things that are really ready to go and fully baked and can be included in contracts in year one, and those things that could really use a little bit more time to flesh out and get the details right. And so what you'll see in the final report is things that we're anticipating being in the RFA and in the contract in year one, and the list of things that we'll be signaling that we're going to continue to work on over the next couple of years, but would anticipate they'd come into contracts in future years. I'm going to go through these pretty quick just because I know we're short on time, but please stop me if you have questions. In terms of behavioral health, there's really three, I'd say that a lot of feedback really boils down to three areas. One, more clear definition of what the accountability is or responsibility at the CCO level for behavioral health. We are not saying that CCOs can't continue to subcapitate, but that there's, we want to build in some stronger accountability in terms of what the CCO's role is for ensuring things like timely access to care and working on that integration between the behavioral health and physical health system.
Will that include standards of care and training, adequate training for the people in the behavioral health?
Chairman Sanderson, we're looking at a whole series of metrics right now that we would include in the contracts that would identify that folks are actually getting the right care at the right time. And the expectation would be the CCOs would be accountable for those metrics and be answering to us and to members. I think the training question's an interesting one. I think it gets to a larger workforce issues that we've also been looking at. Just quickly on those last two in the behavioral health, also looking at stronger network adequacy requirements, and then, as I mentioned, some clearer metrics around behavioral health. On social determinants of health, there's sort of four main buckets here. One, increasing actual investment in social determinants of health and health equity, and this is helped along by by House Bill 4018 that you passed last session, but we want to continue to evolve the rate methodology to make sure that it's incenting investments into social determinants of health. Aligning community health assessment and community health improvement plans. So right now, local public health and local hospitals and CCOs, or multiple CCOs if there's more than one in the region, all do community health improvement plans. We want to bring those together and have really one unified community health improvement plan in communities that's guiding where not only CCOs but other community partners are investing to try to have a collective impact on social determinants of health. In terms of health equity, we're anticipating having a equity plan that each CCO will submit, as well as requiring a single point of accountability within the CCO that's responsible for carrying out a health equity agenda, and then looking at implementing recommendations by the Traditional Health Worker Commission for improving use of traditional health workers and community health workers. In terms of value and paying for performance, what we're looking at is setting a minimum threshold that CCOs would have to have value-based payments on year one, and then a sort of an exit requirement at the end of the 5 years. So what we're looking at is 20% of all payments to primary care providers would be based on value on year one, and then by the end of the 5 year, we want 70% of all payments tied to value with incremental steps in between there. And then I think on the value-based payment piece in particular, we've heard a lot of feedback that, at the end of the day, Medicaid's, while a very significant part of the market, it's still only about a quarter of the market. And so if we really want to move from fee-for-service to alternative payments and value-based payments, we need to try to align efforts across PEB, OEB, commercial markets, and Medicaid, and have a joint strategies to get there. And then in terms of continue to hold down costs, as you know, we've committed to the 3.4% trend through our waiver, but we spent a lot of time looking at what do we think are the challenges that are driving underlying cost growth, and what are some of the tools that the agency could deploy to try to continue to hold down costs. So pharmacy, probably not surprising, is the number one thing we've heard. We also are fairly limited in terms of what we can do under federal law, but are looking to create better alignment across CCO and the state preferred drug list to better leverage the state's purchasing power.
Senator Steiner-Hayward.
Thank you. Mr. Van de Hey, apropos of both what you're talking about and what Commissioner Myron was talking about, volume's really loud today, huh? Okay, I'll sit even further back. Clearly pharmacy is one of the leading drivers of our difficulties in maintaining the 3.4% growth rate. But we also know, and this came up in several other conversations, about mental health pay parity. And as we work to try to attract a robust, highly qualified behavioral health workforce to this state and to grow our own, one of the ways that we're going to have to do that is to make sure they're paid well. And I wondered what kinds of conversations you all have been having about any concerns about whether that would, improving pay in the behavioral health arena would put our 3.4% growth rate at risk, or whether you thought that ultimately providing better behavioral health care would result in lower costs in other arenas and thus would net out in the right direction.
Chair Bonus Anderson, Senator Steiner, sorry, I can't.
That's okay.
Can't talk this morning. Yeah, I think the original concept around CCOs was that some of these tough decisions would be made on the ground, that there would be a global budget and the dollars would be shifted around within a sustainable budget to try to address some of those issues. I think we recognize that within a budget, if you're going to increase mental health payments, that the money's got to come from somewhere, which probably means shifting dollars around from the physical health system to the behavioral health system. I think that there's probably some good arguments that there's ways to do that in a way that would still be budget neutral across the board if you're able to do things like reduce emergency room visits and reduce other costs within the system.
Sure.
But I don't think we've really seen a change in the payments to behavioral health over the last 5 years in terms of parity.
If I could just add to that a little bit, I've talked a lot about the fact that when I started this job, I didn't know much about behavioral health, and I don't know much more now, but I do know a little bit more. And one of the things I'm still trying to get my own handle on is this question of, are we spending lots of money, plenty of money on behavioral health, or do we have badly and historically unfunded pockets, whether it's around provider rates or different kinds of investments in different sorts of treatment? Like a lot of things, I suppose the answer is probably a little bit of both. But I think one of the things we'll need to wrestle with is, for lack of a better phrase, call it deferred maintenance. If what we find is a pocket of deferred maintenance, I think there's a conversation we need to have with you about, is it appropriate to try to catch up that deferred maintenance within a cost-constrained cap, or is that something that we should really look at outside that construct? And we're not there to be able to have that conversation yet, but I think that's ultimately what we need to be able to talk about in some of these areas.
Thank you, Mr. Allen. Thank you, Mr. Van de Hey.
The last piece I'll just say on cost containment that we're looking at is using some more tools to really look at our data and find areas of opportunity where there's outlier costs within the system, or there's regional variations. We've actually gotten pretty positive response from CCOs that this type of information would be helpful for them in terms of where they focus their efforts. There's a whole number of things that we're looking at for post-year one, things like potentially exploring a reinsurance program that would require legislation, so we'd be back to talk with you about that. Further improvements within behavioral health, looking at things like, can we build out the behavioral health home program to look more like the patient-centered primary care home program, where we're really setting clear outcome expectations and then providing technical assistance on how we get there. More work, I think, coming on trauma-informed care practices and work around ACEs. And then through all of this, there's also been recommendations in terms of OHA's responsibility. One of the things that we found is that one of the challenges from NCCO 1.0 is where we were not as clear and explicit within the contract about what outcomes we wanted. And so really trying to keep an eye on that as we're going into the drafting phase of the RFA and contract, of making sure we're really clear about what we're expecting over the next 5 years, and that we've got the organization in place to be able to track that and make sure that we're holding the system accountable. On the behavioral health side, I think this is not directly related to payment parity, but I think really important in terms of how we pay behavioral health providers, and that's to do an analysis of what billing systems we have in place and billing codes, and some of the challenges that are probably in place because we're both trying to move the system to value-based payment, but then also forcing it to still work off of encounters and collected data based on only seeing patients, and so looking to see what opportunities there are there. As I mentioned, the Health Policy Board will wrap up its report in October. October 15th, we'll have a next version of a draft report that will go out on the 28th for one last round of feedback, and then we'll move into the drafting phase for the RFAs. I'm going to turn it over to Zeke.
Chair Monis-Anderson, members of the committee. From a Health Policy Board perspective, I just wanted to share a couple of thoughts. You heard some of the detail from Jeremy, and I know that you have also have the draft report in your hands. You may remember, and as Jeremy suggested, a couple of years ago, we did a listening tour and developed some recommendations out of that around the future.
You need to repeat your name for the record.
For the record, this is Zeke Smith, Oregon Health Policy Board Chair. We developed a set of recommendations out of the listening sessions almost 2 years ago. And while I think those were important, they were at a pretty high level, and they didn't quite provide the level of specificity or kind of roadmap I think that we need as a system as we think about where we want health transformation to go and the role of CCO. So over the last year, we really have had, I think, the opportunity, and I think the Health Authority has leaned their shoulder into the process to make sure that we could get both clearer and more specific about what some of the challenges have been and what some of the opportunities are moving forward. As you heard, there was significant public input to that process. I think that has both been a good dialogue back and forth between key stakeholders and the policy board, and the Health Authority has done a good job of incorporating input along the way. That continues. I think that the report that is in draft right now is different than what we're going to see on the 28th, and will be different than ultimately what we'll get on the 15th in small ways but meaningful ways as additional input is incorporated there. So I just want to note that I think that that's been an effective process, and also that I believe that the leadership of the Health Authority has learned a bit in the process and is effectively thinking about how to engage constituents and stakeholders in their work as they move forward. I also think that the level of policy specificity that is represented in that report and that we will be adopting in October, if all things go as they should, is getting us to a level where we actually have some clarity about what we want to see accomplished in the next 5 years. And so there's both some reality to the fact that those policies are defined in a way that there will need to be some continued adaptation and change over that period of time, but that the policy board has really taken seriously the idea that at this moment in time, we want to be clear about where we think we should be headed and the kinds of change that we're looking for, and that's what's represented in those policy recommendations. I will also just say, for the record, that we think of that report as being a useful document and tool and communication with you all as a legislature as we think about the role that we will need, where we will need additional changes from legislature. It's definitely, I think, a document that supports both existing CCOs and whoever is going to go through the process moving forward about what we're looking for from specific CCOs and communities. And then as much as anything, it's a document that really, I think, defines what kind of role we need from the Oregon Health Authority in its relationship with CCOs and local communities as we move forward. So excited about what's there and think it reflects some actionable work in some meaningful ways.
So if I could just make 2 quick comments to wrap up, and then we'll move on to our next topic after answering questions you might have. First, to the timeline, Jeremy talked about the fact that the procurement process takes about a year from the time we issue an RFA through getting actual signed contracts, and that continues to be the case. When we all came in the door at OHA about a year ago, we were that year was supposed to be 2018, with the contracts to take place in 2019, which would have left us about 3 months to basically do all the work you've just seen in the last 20 minutes or so. And so when we came and talked to you about the fact that we really weren't ready to go and needed to delay the process, I hope that what we've been able to show you today kind of helps justify the notion that that delay was well spent in terms of the quality of engagement and the depth of thinking that's gone into what's coming back from the policy board as part of its final report. Second, we've not finalized the rate setting process for 2019 yet. We'll be able to come back and talk to you in more detail about that in in December. But it's likely when we come back that you're going to learn that rates increased this year at more than 3.4% as they did last year. In these 2 years, that's driven largely by the redetermination exercise we went through a year ago, last summer, that essentially removed a lot of healthy people from the Oregon Health Plan and increased the relative risk and cost of the remaining members. But moreover, you'll also see that on average, a medical trend continues to run pretty high. And so what we'll want to talk to you about then, and what's really a focus of CCO 2.0 on the cost side, is this notion of where our CCOs, and there are multiple CCOs that are successful at driving down those costs. We've got an entire region that came in below 3.4% this year. And what are the tools that work, and how do we drive those tools and get them in more widespread use to be able to do a better job of containing those costs? With that, we'd be happy to answer any questions you've got on CCO 2.0.
And what is the national medical cost rate that?
Oh, I don't have a number in my head.
8%, something
pocket.
like
Do you?
that, I heard.
Well, I know that over the next 5-6 years, the national trend is expected to be close to 6%, about 5.8.
6%, okay. Thank you. Yes,
Thank you, Madam
Chair.
Chair. First question is, what region came in below? Second statement is, thank you for the job you're doing. I see noticeable changes, and you should be commended.
Thank you, Chair Anderson, Senator DeBoer. It's the central and eastern part of the state that on average is below the 3.4% growth rate. And with individual CCOs in other parts of the state also.
You did a fantastic job.
Great. In that case, we'll switch gears to our next topic.
Under time, yes, thank you.
Next, I'll invite Lillian Shirley, the Public Health Director, to the table to provide an update on public health modernization, especially in terms of water and emergency response. Oh, that's not quite it. That's not quite it. Next one. There we go.
Thank you, Director Allen. Thank you. Chair Anderson, members of the committee, my name is Lillian Shirley, and I am the Director of Public Health Division at the Oregon Health Authority, and I'm here today to speak to you. Thank you for inviting us to provide an update on the Oregon Health Authority's water quality program and the health effects of algae blooms. The information I share with you will include our recent experience with cyanotoxins in Oregon's drinking water and discuss our ongoing work to strengthen the public health system's capacity to prepare for and to respond to emergencies, both emerging diseases and environmental concerns. The Oregon Health Authority's drinking water program ensures safe drinking water for everyone. We do that by working with local public health authorities to regulate public water systems. Clean drinking water is foundational to health, and so much so that our Public Health Advisory Board in 2017 included the percent of community water systems meeting health-based standards as one of only 8 accountability metrics for Oregon's modernized public health system. State public health in Oregon implements the Federal Safe Drinking Water Act for the U.S. EPA, the Environmental Protection Agency. They set the standards, and we are responsible to implement those at the state and the local level. There are 3,400 public water systems in Oregon. Most are small systems. 2,500 are above the lower threshold of the Safe Drinking Water Act, and that means they serve at least 25 people. 900 systems in our state fall below that Safe Drinking Water Act threshold, but above our own state threshold, serving 10 to 24 people. The program is fairly complex. It fulfills a range of functions, including both the adoption of standards for our state, review of the monitoring data of the water systems, inspections, certification, engineering plan reviews, as well as investigations. We have enforcement when needed, and technical and financial assistance are provided through the state revolving loan fund, which is a federal source of funding for us. And the programs that we use it for to assess and protect are the source waters to assist very small systems. We work with many partners, including the local public health authorities, the Department of Environmental Quality, and Business Oregon, as well as local community drinking water systems. To ensure safe drinking water to everyone in the state, we increased staffing just prior to the last recession. And the program then, during the recession, lost more than a third of its staff through attrition due to budget cuts. In this environment, the program took on additional work because we've received new federal regulations, and also we're dealing with high-profile issues like lead in water at schools and the Portland Water Bureau's cryptosporidium detections in 2017. There are emerging contaminants to contend with as well. This program currently regulates 90 contaminants or contaminant groups under the EPA's Safe Drinking Water Act. There are many contaminants as well that are unregulated. However, the EPA has a rule called the Unregulated Contaminant Monitoring Rule, or affectionately known as the UCMR, and that requires public drinking water systems to monitor 30 of the unregulated contaminants that are listed by the EPA. So I'm going into detail here because this is an example of one of those unregulated contaminants are the cyanotoxins that resulted from a harmful algae bloom that led to the Salem water crisis. The EPA collects data on these unregulated contaminants that do not have health-based standards set under this SDWA, the Drinking Water Act.
And why don't they? I mean, it affects pregnant women in particular, et cetera. So I'm just wondering why the feds don't pay more attention to these unregulated contaminants.
Well, because number one, I think because the research that resulted in, we'll talk about the advisories later about pregnant women, et cetera, and people with chronic diseases. Most of those studies have not been things that actually showed up as a direct cause with human health, but they are based on animal and laboratory studies that we've extrapolated it to. So there's no real clear, unlike lead, where we do know and we can prove and we have seen actual disease from unsafe lead levels.
Or developmental disabilities, I mean, learning disabilities. There's so many things that are, you know, there's just, I think we're in our infancy on the effects of some of these things on the whole system, including mental health. But that's an aside. Go ahead.
No, but I think that's the aspirational reason that the unregulated contaminants are being monitored and watched, so we can see where they do show up and are there any connections. But you're absolutely right. We are in our infancy in understanding some of these connections. We are concerned that the Safe Drinking Water Act services and the local public health authority don't have enough staff resources right now to provide adequate support to particularly our very small systems. That would include access to technical assistance and on-the-ground work. Okay, so the specifics of this particular crisis, there was a total of 33 days of do not drink advisory for vulnerable populations. The EPA health advisory levels include both a concentration of the contaminant and a 10-day duration of exposure, such that the exposures below these levels are considered safe. This incident in Salem had 5 days with an exceedance of the health advisory levels. We at no time experienced 10 consecutive days. The response effort was locally driven with state support, including particularly the Marion County EOC, the state EOC, and the Public Health Department EOC in Marion County. And the primary effects of this event were restaurants posted notices to inform customers of water quality. Food and beverage manufacturers were advised not to use tap water. So some food processors initially did shut down. NORPAC held their product up until it was tested and before it was shipped out. And breweries suspended production. Some of the secondary effects of the advisory, healthy adults chose not to drink the tap water. And some people showed up to get water with unclean containers. And the use of bottled water generated a particularly large volume of plastic waste through those incidents. The city and the county and the state coordination was key to the incident response. Other water systems stepped in and helped. City, county, and National Guard operated water distribution sites. City engineering consultants installed a powder-activated carbon pretreatment as a precautionary measure. And the Oregon Health Authority adopted cyanotoxin rules within 3 weeks. We are only the second state in the nation now that does have a regulatory review of cyanotoxins and testing for that. We provided, all the responses are local, and our main role at the state level is to support the local response. We did this in Salem by providing consultation with the City of Salem, the Environmental Protection Agency experts. Our Region 10 partners were very active, consultation with the hospitals and the healthcare and public health, supporting for monitor at nearby water systems, which included upstream from the Salem water intake. We provided translations in a number of community languages that were primarily in the area, like Marshallese and others from the Pacific Islands. Thank you. We supported and gave financial support for the 211 line and kept that open. We participated in the City of Salem's Joint Information Center, and we activated our own Incident Command Center for the entire time that the incident was in process. Excuse me. We can't predict the future, but we can leverage this experience and prepare. Our goals for 2019-21 is that the system uses data and partnerships more robustly to create resilient communities that are prepared to respond to health threats immediately, and where planning is inclusive of priority populations that will be affected disproportionately. We will have an increased focus on developing partnerships with our other state agencies as well as local agencies, identify shared goals, shared goals, as well as resources and protocols. Public health emergency preparedness is one of 7 foundational capabilities for our statewide public health system modernization. So how do we modernize? We help Oregonians to survive, recover, and thrive from public health incidents with an emphasis on all of us, which includes all the responders as well as all of our residents. Children, seniors, people living with disabilities are priority populations during any emergency and more vulnerable to poor health outcomes. We use data and evidence-based practices for shared protocols. And we've learned in the last incident that we need to standardize these and have it in one place, for instance, on the web, like we do for fire protocols, where every agency has the same communication protocol. We're working to strengthen our healthcare partners' capacity to respond effectively, and that was shown with the hospitals and clinical systems that were impacted by this crisis. And we are continuing to build partnerships, including interagency and public and private partnerships with community groups in regions across the state. Currently, public health emergency preparedness is funded solely through federal funding, and we are using these dollars. I don't know. Am I contagious? Or I think I'm allergic to my boss.
I'm immunized.
Thank you, Mr. Allen.
So we're using the dollars that we do have most effectively for system-wide changes. With general and additional funds, we'll be able to scale our efforts to reach all communities in Oregon. These efforts are part of our larger legislative mandate to modernize Oregon's public health system. In 2016, the Public Health Advisory Board, in response to House Bill 3100, developed a phased-in approach based on county by county and a state public health assessment of where our biggest gaps were for modernizing Oregon's public health system. Our Public Health Advisory Board confirmed these phases as a pathway for modernization in 2018. With the investment that the legislature made in 2017-19, we focused on shoring up capacity to prevent communicable diseases and address communicable disease health disparities, and that's phase 1 here on the chart. If further investment is made, we'll begin to continue to build environmental health capacity from the shored up capacity in communicable disease and emergency preparedness. We'll place the public's health at the forefront of local planning and implementation to protect people from emerging environmental health threats. So the next phase for this work, modernizing public health, the landscape has changed dramatically in the recent years as we live, travel, work, and play have changed. Changes in Oregon's climate make the state more susceptible to certain acute and communicable diseases, such as cyanotoxins that were previously not a significant health threat, as well as long-term exposure to unhealthy air quality, particularly in the southern regions of our state. The demands on Oregon's public health system have continued to increase as the rates of the public health investment have decreased or remained flat. So this has constrained in many ways the system's ability to nimbly respond to acute and communicable outbreaks, as well as to proactively plan for changes needed to better manage and prevent these emerging crises. But we do have the roadmap, and that is to continue our work to transform into a modern public health system with tools, skills, and resources to prepare for these emerging threats. We can't be successful in any one area without capacity in all the other areas. And we recently submitted to you in the legislature our interim evaluation report that documents the progress and the systems changes and the outcomes that we've achieved already in the first 6 months of operations from your first investment in the last legislative session. For follow-up, we'd be happy to meet with you to discuss individual outcomes in areas throughout the state that have identified local issues to address in collaboration with counties, CCOs, hospitals, and community groups to work on the first issues, health equity and communicable disease, where we've seen results already to that investment. And I believe with these presentations from the Oregon Health Authority, you had uploaded our public health modernization first evaluation report.
What we really need to know, though, there was a lot of fear in this community, in the Salem community, when the algae bloom, the water is warm, the algae bloom came, and this problem is not going to go away. So our reliance on water from algae bloom waters is not going to go away, and I am concerned, and I think the people here in this community are concerned of how to prevent that. Do we need to look at wells? Do we need to look at, I think we can't just wait for another outbreak. We need to be prepared for other ways to be able to have, pure water or drinkable water to our constituents. So is public health, the Water Bureau, looking at how we can address this? Because if Salem's a community, and it's a pretty large community, I know that we've had algae blooms at Detroit Lake, but I'm not sure if they rely on that water for drinking. But I think that's the concern. Where are we going to go? Are we just going to wait till they happen again and people just go and get their bottled water, or has that been addressed?
So I think it is being addressed, and I think it gets back to the reliance on partnerships. It is not one agency. It is not one level of government. It is a continuum, and so from source water to the tap, there are a lot of agencies across the state that are looking at infrastructure, modern methods of treatment, plus
What about
testing protocols.
filter systems? I mean,
Well, that-
this is a huge,
It is a huge.
and we need to start now.
Community-wide system that requires a huge community-wide partnership to address it. Yes, you're absolutely correct.
If I could just add a little bit, and Lillian will swat me if I stray off into things that I don't know enough about yet. But this is while we have had algae blooms in Oregon forever, this is the first time we've ever had cyanotoxins actually show up in a drinking water system as opposed to somewhere upstream of that drinking water system. So the notion of algae blooms is old, but the threat from cyanotoxins, I think, is increasing. As we found in the case of Salem, it really was the powdered carbon addition to the treatment system that helped them deal with that issue. And I think two things that we're doing at OHA around this. One is the rule around testing. So now that we understand the nature of the threat is increasing, we're trying to provide access to more information so that we know what's in the water. And then the issue around partnerships and technical assistance around things like what kinds of treatment steps need to be taken, what do water systems look like, need to look like today that may be different than they might have looked like 50 years ago if the nature of the threats have changed. And I think that really is the crux of both what the program is about and what investments in it. And thank you to Senator Steiner Hayward and her committee at Ways and Means yesterday for helping us add some resources to continue to be able to provide more technical assistance and more partnership.
Thank you. Any other questions? Thank you.
I was just going to, thank you, Mr. Allen, for the shout out. I appreciate that. But just so the rest of a little bit more detail. Yesterday in the Human Services sub of Ways and Means, we funded 2 new positions at OHA. A bunch of them, we did some stuff for the military department. We did some stuff for DEQ. We funded stuff in 4 different agencies, all related to this water crisis. And the issues around communication came up a little bit then. Obviously, it's going to be really important. I mean, as Ms. Shirley quite rightly pointed out, I remember coming into the building pretty regularly during that period of time and having people that I personally know are completely healthy adults say, oh, don't use the ice because of the cyanotoxin. I'm like, yeah, no, that's not the issue. You're not the target audience here. So I do think that one of the biggest challenges facing public health, not just about this particular issue, but about public health crises in general, is how do we develop a robust network of trusted partners who can communicate? And that has to include reaching out to our more diverse populations, right? I mean, you're going to talk a little bit about some of the equity issues, and that's really important there, as well. So I think that those are the kinds of conversations we do need to be having to make sure that Oregonians have confidence in their water system when they should, and when there are times of crisis like this, they know how to respond appropriately.
Thank you, Senator Steiner Hayward. Yeah. Okay.
Thank you very much.
If there are no further questions, we've got one more topic to cover, and we'll swap out again while Dr. Harganani comes up. Madam Chair, when would you like us to be wrapped up by?
You have until 9:25.
9:25, got it, we can do that.
So you're fine.
Great. So today we wanted to spend a few minutes talking about behavioral health in general. We're going to talk a little bit about current activities. We'll also tee up some things that are in the early stages of work, and then some future view. You're really going to hear today primarily about kids, about veterans, about substance use disorder, and then a specific focus on the Portland metro area that we've been working on. In terms of current activities, some tools that we have been working to increase the use of, this often is in the context of the U.S. Department of Justice agreement called the Oregon Performance Plan, around a variety of tools and steps that we need to implement to meet the terms of that agreement. Assertive community treatment, it's an incredibly powerful, also labor and cost-intensive system of service that provides assistance to people with severe and persistent mental illness in their community, ideally in their housed circumstance, but in their unhoused circumstance, if that's where they are. And the idea is to provide an intensive level of services that keep them in their community rather than moving them to some kind of a residential treatment service, which often disrupts housing as well as other community connections. We now have mobile crisis services in every single county around the state, and this is the ability to respond in real time to people who are in crisis, and as part of a strategy around how to provide tools to first responders other than jails and hospital rooms, emergency departments as a way to respond to those crises. And then we're in the midst of a multi-site pilot around certified community behavioral health centers. This is taking the idea of a patient-centered primary care home and kind of turning it on its head, where the one is physical health with an integration of behavioral health into it, and starting out primarily as a behavioral health service provider and integrating physical health into that, creating a behavioral health home as a way, particularly for people with more serious mental illnesses, to be able to get treatment that is more consistently aimed at their specific needs. I'd like to spend a few minutes talking about school-based mental health services. I know, Senator DeBoer, this is a topic that you're very interested in. There are really kind of three buckets of funding that we at OHA use to support school-based mental health services, and I want to spend a minute talking about each of those. A little bit less than $7 million flows through the Public Health Division to school-based health centers. There are about 76 SBHCs across the state, and as a result of this funding, each and every one of those school-based health centers now has a behavioral health professional in some amount of time in that school-based health center. However, the demand far outstrips that investment, but it's a good starting place that we've now got behavioral health as a part of the package of services that we receive. About 5,000 individuals have received care from mental health professionals in that setting over the course of about 35,000 visits during the 2016-17 school year. The top 5 diagnoses that they're seeing are generalized anxiety disorder, PTSD, depression, adjustment disorder, and ADHD. In addition to that, a little bit less than $2 million flows from the Health Systems Division through the county funding that we provide for behavioral health to a variety of school districts, largely, though not entirely, without school-based health centers to provide behavioral health resources in that non-clinical kind of a setting. We work with schools and counties that don't have SBHCs, counties with elevated risk factors related to behavioral health, according to the 2013 Oregon Healthy Teens Survey, based on the reported availability of school-based health services and a commitment to partnership with the local school district. We have 45 sites that these investments have been made in. 43 of them do not have a clinic. The 2 funded schools with a school-based health center have very high mental health needs, and so we're trying to augment the level of service in those particular areas. And what we do is we support mental health provider staffing, consultation with school personnel, and educational groups for students in the schools. Finally, we do fund behavioral health through coordinated care organizations, and those relationships vary, as you would expect with 15 CCOs. They vary considerably across the state. School-based health centers are able to bill the Oregon Health Plan, but only about half of the students that those clinics see are on Medicaid, and so that's an imperfect answer to that funding resource. And we have resources in the agency that can work with school districts to help improve their ability to bill for Medicaid when that's appropriate. And this is just a simple little graph to show, I think, the power of these investments. This is data related to youth suicide attempts. The dotted line with the orange box represents the trend from 2013 to 15 in schools that do not have increased investments and those that do. And you can see that while the decrease is maybe a little bit small in the investments compared to the increase that occurs without those investments, it's a dramatic difference in the rate of teen suicide attempts. Let me shift gears now and talk for a minute about Veterans Behavioral Health Services. This is a partnership project between the Health Authority, the Oregon Department of Veterans Affairs, and the U.S. Department of Veterans Affairs to identify ways to improve the behavioral health services we're able to provide to Oregon's veterans population. This is based on a $2.5 million funding stream that you provided, and it's got some key components. I think the biggest thing I would point to is this notion of peer-to-peer health services, and I think throughout what we've been talking about today, peers is an important theme. In this case, this is veterans working with veterans, and we think that's an incredibly important element of serving the needs of this population. Also, the general idea of when we go out and ask questions about what do we need, that we're talking to veterans. Some things that we were able to start implementing, that we're beginning to implement right now, that we didn't need to wait for any kind of an assessment on, particularly focus on veteran suicide prevention through enhanced training and 9 statewide trainings for clinical providers that'll be coming up in the next year. We also, particularly at the request of the Oregon Department of Veterans Affairs, funded and hired a behavioral health veterans liaison in our agency who can help coordinate this work and coordinate the work we do with ODVA to make sure we're hitting the mark. And as a health agency, being able to coordinate what we need to with the veterans agency, since that's a population that we don't have specialized expertise in, but we do have specialized expertise on the behavioral health side. And the last piece is we're in the midst right now of a comprehensive assessment of needs and gaps in the behavioral health system for veterans. And again, key to that is making sure that we're talking to veterans and providers who work with veterans, so that we're really able to bring this down to the ground level of what do people tell us that they need who are in the circumstance most needing services.
Madam Chair?
Yes, please.
If I could just comment quickly. My understanding from talking with advocates in the community is that the department's been doing a great job of bringing the consumer voice to all sorts of conversations around improving behavioral health services. I just want to thank Mr. Allen and Dr. Haganani and their teams for this important aspect of their work, because without the consumer voice at the table, we really are not going to do a good job of transforming our ability to care for people when they're in the most difficult times. So thank you both very much, and please give my thanks to your team.
Thank you. Let me turn now to substance use disorder and recovery. A variety of things that are underway right now. We've been, in terms of complying with House Bill 4143, we're designing and implementing 4 pilot projects around the state to use peers. Again, peers coming up to facilitate access to care for opioid use disorders. Project coordinator has been hired, and we're working on an evaluation team right now. Examples of projects that are in development: Coos County is proposing to place peers in emergency departments. Similarly, Multnomah County wants to use peers in hospitals to facilitate access to services across all levels of care. 2 other counties, Marion and Jackson County, are working on similar kinds of plans. We're using federal opioid funding to expand on these pilots and be able to not only expand access to treatment, but be able to learn from the successes and replicate those elsewhere. We are in the midst right now of pursuing a substance use disorder waiver through the Centers for Medicare and Medicaid Services. CMS is encouraging states to apply for these waivers. Right now, the state cannot use Medicaid funding in most facilities because of what's called the IMD, or Institute of Mental Disease exclusion. Basically, federal law says that any facility with 16 or more beds is prohibited from being reimbursed by Medicaid. And what we're trying to do is to waive out of that restriction so that we can expand the supply of treatment facilities available for individuals with substance use disorder, and we expect to find out more about that later next year. Oregon's received $6.5 million a year over 2 years from the federal government to combat the opioid crisis. We'll receive another $7.75 million over the next 2 years. Some of the things we've done with that funding is an expansion of opioid use disorder treatment programs to rural communities, pilot projects to provide peers with medication-assisted treatment in jails, and making sure that we're providing naloxone to first responders to counter opioid drug overdoses. Over in House Health yesterday, we heard heard from Representative Hayden, his relating, I think, 4 overdoses that occurred in his community over the previous weekend, at least 2 of which were reversed through use of naloxone. And we're trying to make sure that we expand access to naloxone all across the state in terms of those who are able to use it, and as well as the supply. In that light, this graph tries to show a little bit of where we are in terms of overdose deaths by source of drug across the state. And this is death certificate data, so it's pretty gold standard data in terms of its quality. And you can see that over time, the purple line is pharmaceutical and synthetic opioids, and the death rate has steadily decreased, and that rate of decrease has steepened in the last few years. Heroin has been relatively flat. Unfortunately, methamphetamine and other stimulants is increasing. I think this shows the wisdom of the governor's executive order on addictions, really focusing on addiction broadly rather than specifically calling out a particular drug as the means shifts.
Senator Stenny.
One of the conversations we've been having on the opioid task force, as you are certainly aware, is the issue of the synthetic fentanyl that's starting to become a problem. We have not seen as big an upsurge in the state yet, and I note the yet, but I think we all fear that it's on the horizon. Do you think that my understanding is the fentanyl is contaminating stimulants as well. Do you think that some of the increase from methamphetamine and stimulants is related to synthetic fentanyl, or do you think it's all straight stimulant-related overdoses?
I might turn to Dr. Harganani on that, but one other factor I would at least anecdotally add that has been suggested is when you have someone who's in medication-assisted treatment for opioids, methamphetamine remains something that will get them high when other things won't due to MAT, and so there may be some substitution there, but would you like to expand on that?
I'm sorry, go ahead, Dr. Harganani. I'll add my comment in a second.
Chair Monis Anderson and members of the committee, for the record, my name is Dina Harganani. I serve as the Chief Medical Officer for the Oregon Health Authority. And Senator Steiner-Hayward, thank you for your question. I can speak to at least to say that we know methamphetamine use in death rates are on the rise for sure. I can't speak to whether or not the distinction we can make in this particular data with regards to peeling out fentanyl deaths. I do believe we can, but we will get that information back to you.
I would just say, and I would appreciate commentary from those in the audience more knowledgeable than me, but Mr. Allen, my sense is that in general, people with substance use issues go either up or down. I mean, some people mix them to get a balanced effect, but they don't tend to, if their issue for which they've ended up receiving MAT has been related to opioids, which are generally considered quote-unquote downers, then they're less likely to substitute the high for meth. Now, that's not exclusively true, and there are exceptions, but that's been my understanding. I appreciate correction if people think I'm way off base.
Yeah, and I didn't mean to state that definitively by any means. It's simply something that's been suggested to me by others and that I know is out there as a potential.
It's not that big a deal one way or another, but I just think we just need to be thinking about that. No, I'm done. Thank you, Senator.
Well, your chart is surprising to me a little bit. The discussion has been that deaths from opioids is on the increase, but your chart suggests that there actually is a fairly strong trend going down, not up. And heroin is about the same. The 4 deaths that Representative Hayden was speaking to was bad drugs. Essentially, it was the concept of heroin being laced with, I don't know what the stuff is, but they've been saying coming in, it was just bad drugs.
Let me add one other piece of information before we move off this slide. Alcohol is not captured here, and when we think about broadly trying to attack addictions, obviously, alcohol is an important part of the mix. Its impact far outstrips any individual illicit or illicit drug. The trick in trying to capture it in this sort of a data format is where a drug overdose from heroin is a pretty binary. Either that's what was the cause of death or not on a death certificate. Deaths due to alcohol abuse are much less binary and harder to identify. identify in this kind of a data source, and so it doesn't stack up neatly in the way these do, but it is definitely on our radar as part of our approach. With that, I'd like to turn it back to Dr. Harganani to talk about our regional approach in the Portland Tri-County area, and we can wrap up in a couple of minutes.
Yeah, wrap up in a couple of minutes. Thank you.
Absolutely. Chair Monis-Anderson, members of the committee, again, I'm Dana Harganani, Chief Medical Officer for the Oregon Health Authority, and I'm pleased to be here and will very briefly just give you an update on some of the work we're launching in the Portland Tri-County area. This is a regional behavioral health initiative, and it's really structured to bring together key stakeholders and individuals with lived experience to tackle some very specific and pressing issues for the region. And very briefly, our agency decided to step in and provide leadership in particularly the Portland Tri-County area for three particular reasons. One, with the closure of family care, we certainly heard loud and clear from the community through community forums that there are concerns and opportunities for improving the behavioral health system in the region, and particularly illuminated by different approaches that were occurring around behavioral health services. So we know that we have an opportunity here in the Tri-County area. We certainly have committed partners. This is a second opportunity we have. And thirdly, I think with the population focus in the Tri-County area, we can certainly have the potential for significant impact while also sharing in our learnings in other areas. As we, the agency, step into this work, we're really being clear and intentional about the leadership we're bringing to the table, as well as our focus on being action-oriented to really have measurable change over a short period of time. So I will not go over the timeline. We're really just getting here. We've done planning over the summer and getting ready to launch our first regional meeting, getting the right stakeholders and partners at the table in November. Through our planning this summer with input from leaders in the community, it's been really clear that a focus is really intended around peer-delivered services with a particular emphasis around substance use disorders. And we are going to be launching our first meeting, which is really going to be focused on really clearly identifying what the goals are, what our measurable change will look like, what strategies we're going to be undertaking. There are a number of excellent strategies already underway in the Tri-County area that we think could be expanded or leveraged from. This is a brief overview of some of those. I'll just give a couple examples. One, we know there's some great work to integrate peer-delivered services with women who are pregnant, suffering from substance use disorder, and how to integrate those services, and we see an opportunity for expanding that. We also know there's a significant impact, a traumatic impact to young children living in families who are affected by SUD, and opportunities to expand work to wraparound services to those families. There's also additional opportunities to expand medication-assisted treatment that's already underway, and opportunities to leverage some great programs that are happening there. And I'll just, again, very briefly add that, as we start off this work, we've been very intentional about entering this with a true equity lens. Some of the leaders we've been working with have come together to really articulate what that lens should look like as we proceed in this regional work, and where the specific decisions and organizational steps need to be really considered from that equity perspective, and appreciate the leadership in the community and from our Office of Equity and Inclusion to keep that at the forefront of this work. So we'll end there, and happy to answer questions.
Thank you very much. Thank you, Pat.
Thank you.
All right. With that, let's move to Department of Consumer and Business Services, Cameron Smith, Andrew Stolfi, and Rick Buckwell.
Good morning, Chair Monis-Anderson, members of the committee. For the record, I'm Cameron Smith, Director of the Department of Consumer and Business Services, and that's all the time we have for our update today, given OHA's excellent but lengthy presentation. Director Allen has forgotten all of the good work from the team at DCBS that we had to share. Pleased to be joined by Andrew Stolfi, the Insurance Commissioner for Oregon, as well as Administrator for Division of Financial Regulation, and also Rick Blackwell, our Policy Manager for DFR. We will have a short and quick update on our rate review and stabilization efforts, and happy to take questions that come up during and also at the end. As an overview, we have seen a lot of changes in the healthcare policy at the federal level over this last year and a half. We've seen the multiple efforts in Congress to repeal the Affordable Care Act. We've seen reduced support for the health insurance marketplaces. We've seen the zeroing out of penalties for individual mandate in the tax reform at the end of last year. as well as changes in short-term limited duration plans and association plans. We also have a broader lawsuit pending brought by many of the states against the Affordable Care Act that is pending in federal court in Texas. So all of this has added great uncertainty both for Oregonians, employers, as well as insurance carriers offering plans. But in our update, you'll hear the good news that there is relative stability in the Oregon insurance marketplace. And a big reason for that is all of your support and broad stakeholder support for the Oregon's reinsurance program that has helped to hold down rates by about 6%, both for the 2018 plan year as well as next year, 2019. And we're funded for those 2 years, and that will be a key question as part of the health funding package in the 2019 session, both for OHA's larger budget, but as well as trying to continue that reinsurance program that has broad supports both by industry and consumer advocates. But even with that success that you'll hear today and the relative stability, we never want to lose sight that healthcare costs are still a significant portion, both for Oregonians and their families, as well as businesses and employers, and demands our continued focus and attention. With that, I'll hand over to Andrew on details for rate review.
Thank you, Director Smith, and good morning, Chair Monos-Anderson, members of the committee. Cassie, for the record, my name is Andrew Stolfi. I'm the Insurance Commissioner and Administrator of the Division of Financial Regulation. And this morning I'll talk about three things briefly before handing it over to Rick. That's an update on the 2019 insurance rates, which were set a few weeks ago, and our recent responses to federal actions around short-term limited duration plans and association health plans. So starting with the rate review process in 2019 rates in the individual and small group market. So in July, following a thorough and transparent review process, those rates were approved and announced. To give you a little context for the 2019 rates, I'll tell you briefly about the current 2018 rates. So for the current or 2018 plan year, we have 7 insurers offering plans in the individual market, with multiple plans being offered in each of Oregon's 36 counties. Initial rate requests for 2018 were between 6.9% and a 20.7% increase, with final approved rates for 2018 landing at between 3.5% and 19.2%. In the small group market, we currently have 9 carriers offering plans around the state. Initial small group rate requests for 2018 were between 1.8% and 8.5%, with final rate decisions coming in between 3.3% and 10.1%. Against that background, I'll turn to the 2019 rates. These rates were filed with us in May of this year and have gone through a rigorous and transparent review process, which included public hearings and public comment to make sure consumers are provided the opportunity to weigh in on the health plans that affect them and make sure that rates adequately cover their health care costs without being too high or too low. In the individual market, the department approved rates for 7 companies with average rate changes from a 9.6% decrease to a 10.1% increase. This compares to initial rate requests, which ranged from a 9.6% decrease to a 16.3% increase. Those are the ranges. Another comparison would be a statewide weighted single number for an increase. So for 2019, that is 7.3%, which compares the 2018 single rate weighted rate increase was 13.8%. In 2017, it was 27%, and in 2016, 23%. Additionally, I could note that all of the carriers maintained their current service areas, with 2 insurers actually increasing coverage. Kaiser expanded into Lane County and Pacific Source into Lane and Yamhill counties. In the small group market, the department approved rates for 9 companies with average rates ranging from a 4% decrease to a 7.2% increase, compares to initial rate requests of a 4% decrease to a 9.4% increase. To give you a similar singles weighted statewide average, for 2019, it's a 2.1% increase, which compares in 2018, it was 8.2%, and 2017, 4.6%. Turning to some of our recent responses to some federal actions, starting with a new federal rule on short-term limited duration plans. In August, the Trump administration finalized a new federal rule intended to expand short-term limited duration health policies. These are plans which were originally designed to fill short gaps between coverage. They generally do not cover essential health benefits such as preventative services. They generally exclude pre-existing conditions and have relatively low coverage limits. The previous federal rules limited short-term policies to 3 months in length. House Bill 2341 from the 2017 legislative session amended Oregon state law to match the prior federal rule. And as the new federal rule does not preempt state laws, short-term policies remain limited in Oregon to 3 months in length with a restriction on renewals for 60 days. The department's currently reviewing the disclosures that are required to accompany these policies to determine if they need to be strengthened. And I can note that in the second quarter of 2018, there were only approximately 3,000 of these policies in force. Finally, on the new federal rule on association health plans, in June, the Trump administration finalized this new federal rule. It seeks to establish new, less stringent criteria to determine whether a group or association is a bona fide association under federal law by redefining the term employer in ERISA. Importantly, the rule makes clear that it does not modify or otherwise limit existing state authority to regulate association health plans. Despite the lack of preemption, the department was concerned about the negative effects the new rule could have and would have on Oregon's individual and small group markets. And in July, the state joined 10 other states and the District of Columbia in a lawsuit challenging the rule. And on September 10th, we issued a bulletin that summarized and clarified relevant Oregon law related to association health plans and informed stakeholders that we will continue to enforce all Oregon laws applicable to AHPs as they existed prior to the issuance of the federal rule. So I'll pause there, and Rick will give a couple quick updates on some other things.
Really quick question about this issue, Mr. Stolfi. I want to clarify something you just said. If, in fact, the association, the less stringent rules that the Trump administration has put forward go through, does that mean that these associations would or would not be considered ERISA entities under current federal statute? I.e., would the state still have the capacity to regulate what they do or don't provide in terms of coverage to their members? We do not have that capacity with ERISA entities, but we do with smaller businesses that buy in the group market. Which would this count as?
Chair Anderson, Senator Stenner-Hayward, the federal rule has been finalized and put into place, and it seeks to change through rule a definition of ERISA, the definition of employer in ERISA, and to expand that definition because of the some problems we've seen with that led to us joining the lawsuit. If you're asking about the result of the lawsuit?
No,
Okay.
I don't think I asked my question. I understood what you just said. I got that part. But then you said that it didn't preempt the states from how they deal with associations, which I thought meant that perhaps associations were currently treated differently from traditional ERISA players. You think about large businesses like Intel or Nike or Fred Meyer or whatever that self-insure as ERISA companies, right? And we as a state have no capacity to regulate what kinds of coverage those companies provide to their workers, essentially. That's what federal law says, right? We only have the capacity to regulate what happens in the individual and small group market, right? Or in terms of when we pass insurance mandates, for example, of things that have to be covered, they only cover the individual market and the small group market. They don't cover these large entities. So, assuming that the lawsuit is unsuccessful, all right, let's just assume that worst case scenario, which I think is a worst case scenario. Anyway, assuming that scenario, does that mean that these new association groups would therefore qualify under the federal definition of ERISA, and therefore the state would be unable to regulate the coverage they provide? Or is there a separate set of groups for these associations that relates to that lack of preemption thing you were talking about? That's what I'm trying to clarify.
Understand. Chairman Anderson, Senator Steinberg-Hayward, the federal rule is very clear that it does not preempt any authority that the states had before issuance of the federal rule. And there are within ERISA exemptions for states that give states the authority to different degrees to regulate MIWAs and AHPs. The rule does not change that authority.
Okay, thank you.
Chair Modest Anderson and members of the committee, for the record, again, I'm Rick Blackwell, Policy Manager with Division of Financial Regulation. Just give you a couple quick updates on some additional stabilization efforts that we're working on right now. Director Smith mentioned the Oregon Reinsurance Program rulemaking. So we've been going through that process since about April of this year. We've met 4 times. During the August meeting, the draft rules were put forward that we've rolled out for consideration with the advisory committee. The rules cover, the standards under the bill require us to set the attachment points, the point where reinsurance applies, the reinsurance cap, where how much can actually be paid out under the program, and then the co-insurance rate, the amount paid against the claim on the deductible. So those values are out in the rule. Currently, parameters are set at $95,000 for the attachment point, $1 million cap on the reinsurance, and then the co-insurance rate is currently proposed at 50%. So all 3 of those will still need to be vetted through the advisory committee and then eventually through the public process that we set up for all our administrative rules. Some of the other areas that the rules cover are how to calculate payments, how we audit the information actually submitted to us, and how we pay out claims to eligible insurers. So we're fairly close to filing. Once that's done, we notify both the committees and leadership that we intend to file the rule, as we do with every rule under the APA, and then about a 49-day process from notice to the legislature to the enactment of the rule. So we'll keep you posted on where that goes. The other one is a multi-year project we're starting that looks at geographic rating areas. So since the 90s, Oregon's been split up into 7 different rating areas. It's really a kind of a clusters of counties that was initially set up for, I think it was grandfathered group plans, but kind of taken a life of their own after the passage of the ACA. There can be variations in the premiums between those geographic areas. And so one of the things that we're looking at is trying to see that, given that there's been a lot of demographic change in the state since the 90s, we want to make sure that those rating areas are still appropriate, and go through an actuarial study to make sure that if changing those areas might actually create some positive impacts on rates for Oregonians. So we've applied for and received about $282,000 from CMS, and we'll be applying that money towards an RFP to find an actuarial service that can help us with that program.
Great.
And I'm sure that we'll be back in this committee to talk about that as well.
That's great. Yes, Senator Steinberg-Hayward.
And this is not a surprise, I promised to Mr. Stolfi, because I asked him if I could ask this question, even though it's not entirely related. Last year, this committee heard before it Senate Bill 860, which was a bill that required DCBS to look into the issue of mental health pay parity. And I'd be very grateful for a quick update. I know that you weren't required to report until September of 2019, but that's a long time from now. And I'm just curious, and it's a long time after the initial bill was passed. So I'm just curious about the status of that investigation and how we're moving along.
Rick, do you want to take that?
Sure. Chair Monis Anderson, Senator Steiner-Hayward. So we have, I'll give you the timeline and the vendor actually, and we can go from there. But
Fabulous.
We've selected a vendor that has assisted us with other matters around insurance solvency. So it's a known quantity to us. They're called Risk and Regulatory Consulting. The timeline that we've sketched out with my colleagues in compliance is that we'll be issuing a data call sometime in November of 2018. So the data that the vendor will need in order to complete their work. Draft is due from them May 31st of 2019, and then the report is due to me June 30th so that I can come and deliver it to you by the September deadline that's listed in the bill.
And if I may, Madam Chair, so the initial bill language, and I went back and looked at it just now to make sure I wasn't misremembering, says that by September 19th, of 2019, you're supposed to report to us on the status of the investigation and any rules that the agency has adopted in response to it. So what I think I hear you saying is that it's unlikely we're going to see any major changes prior to the September 2019 report.
Chair Monis Anderson and Senator Steiner Hayward, the bill also does say that we can come back and talk about other actions taken by the department in response.
Okay.
So there may be, this is way in the future and I can't say for sure, but if there are some sort of compliance case that needs to be taken, we could discuss it then.
Madam Chair, Senator Steiner Hayward, a lot of ongoing work both out of the education and outreach team, just so Oregonians are aware of what the both federal and state laws are protecting that mental health and physical health parity. The consumer advocacy team is another great way that we can begin to see trends of different opportunities when it's not aligned in the market. And then ultimately that power through the market conduct examinations to truly do deeper dives where those trend lines point is another great tool going forward on mental health parity.
Thank you. So nothing precludes the agency from taking some action even in the process of the data being gathered?
Correct.
If trends are identified?
And those are always ongoing. And even also out of the opioid task force report, even some other barriers to
That was a great report,
treatment.
by the way. Mr. Blackwell and his team did an amazing job on that report. Amazing.
That was actually me, Senator. I just wanted to take credit.
Certainly, Mr. Smith, that's exactly what I meant to say.
Director is my ghostwriter, so.
Any other questions? Thank you very much. Cameron, if you just stay there, and then Lee, Senator Byer, stay at your place, and then Representative Nosen. And, oh no, and I thought Representative Fahey, right? That's why I said for Senator Byer to stay here so you could come on. Is that all right?
Sure, Madam Chair.
I will give you
You're the chair.
I'll give you the prerogative to start.
Well, thank you, Madam Chair. You'll recall that last session we spent some time talking about a lot of different ways to try and put a cap on some of the growth in healthcare costs. One of those was we started out looking at what Maryland was doing, or wanted to look at what Maryland was doing in terms of hospital rate review. So we created a task force. Senator Seibert, Hayward, and I were on that, along with Representative Nosen, Representative Vahey. What was important to me as we put it together is it would not just have a bunch of legislators looking at it, but actually bring in professionals in the field from the insurance side as well as the healthcare side to look at that all, and we did that. Mr. Dopplers, our former committee staff, led that and did an extraordinary job of looking at everything across the board. I think the bottom line is we learned a lot. We heard from a lot of people in different states what they're doing. It's interesting how much people are doing in other states. As we looked at the Maryland model, we discovered that they're actually changing their program frankly look a lot more like what we do with CCOs, with the difference being that they're doing system-wide rather than just the Medicaid population. We also realized that it would be harder for us to mirror what they were doing because of the fact that they have waivers from CMS on Medicare, which made it a little easier. But we did learn what others are doing in terms of reviewing that. We became particularly interested in what Massachusetts and Vermont were doing to try and put a rate cap on. And without going into a lot of detail, and I'll let my colleagues do more of that if they wish, the end result is we had a pretty much unanimous agreement among the committee. One person disagreed and didn't disagree with the outcome, was concerned that we didn't have all providers necessarily included in the discussion. But we'll be bringing back a bill for consideration in the next session that would impose a rate cap on the system, and by the system I mean from insurers through providers, with the understanding that people would try to live under that, and if they didn't, they would have to come in annually and explain why not, and perhaps introduce a a corrective action plan or to bring them back into that. I think it puts some downward pressure on rates, adds more transparency, and I think starts moving us in the right direction. We did reject the regulatory model as a committee. Personally, as an old regulator, I didn't necessarily agree with that, but I've learned in my time in the legislature, you accept what you can get. And so we will attempt that. And that's an overview, Madam Chair, and you will be seeing legislation introduced in the next session.
Great.
Sure. Okay. For the record, my name is Rob Nose. I'm the state representative for Southeast and Northeast Portland, House District 42. I think the senator did a pretty good job of giving you a high-level overview of what our committee did. I'll just dwell a little bit on what the state of Massachusetts is doing and what we're contemplating looking at based on their model. The state of Massachusetts basically sets a benchmark. They call it a benchmark for what the rate of medical inflation or some other terminology around that will be, and then they hold every entity in their state participating in healthcare, broadly defined, to that benchmark. And so we are pretty intrigued by that model based on the fact that, as the senator said, we don't think we can, without a waiver and a lot more reimbursement for our Medicaid population, do what Maryland is doing with hospitals. We think trying to create that kind of entity and approach here in our state might be the best bet. And so our report basically says we think the Oregon Health Authority should be given a little bit of resource to study the Maryland agency that does this a little bit more thoroughly and come back and make a report to us and tell us, what kind of budget and staffing does this entity within the Oregon Health Authority or maybe its own agency need to have? How would we transition to this new proposed model? How are we going to brace the healthcare industry for a change in approach? What methodology would we use to come up with a benchmark? So, we've been using 3.4 for OEB and PEB and our CCO Medicaid program. How are we going to discern what that rate should be? What's going to be the revenue structure that we're going to use to pay for this department or agency within the Oregon Health Authority? And then what sort of enforcement mechanism are we going to have when something out there in the healthcare space doesn't meet the benchmark? How are we going to examine that and then get them back to being in line with the benchmark that's set? I was sort of, with my colleagues in the House, I was saying, I think appropriating a little bit of money to the Health Authority, adopting whatever bill it does, I think we're going to start it in your chamber, Madam Chair. I don't think that's really the controversial bill. That's sort of like going away and studying this a lot more and telling us what you need to actually be able to do it and what statutes. The real hard part will be in 2020 or 2021 when we have to say, okay, we're going to do this, and here's how, and then that's when I think the debate will get a lot more interesting.
Great.
Representative Fahey?
Thank you, Madam Chair. Representative Julie Fahey from West Eugene Junction City. I just want to echo Rob's comments and Senator Byer's comments and add that on the concept of the healthcare benchmark, I support the committee's or the task force recommendations. And I just think it's important to say that setting a goal doesn't mean that we're necessarily going to see changes in the healthcare system. Setting a benchmark is necessary, but it's not sufficient. So in many ways, it tells us where we need to go and why, but it doesn't tell us how to get there. And that's both us in terms of providers. It's sort of a hands-off approach. We're going to set this benchmark, but we're not going to be we're not going to dictate to providers, here's how you have to meet this goal. And it's also it also doesn't necessarily tell us how to get there from a state level in terms of it's not. I see the benchmark as being a continuation of our work on healthcare and not necessarily the end point. There are other approaches that we considered in the task force, a statewide accountable care organization, global budgets for hospitals, and those approaches are not necessarily mutually exclusive with the healthcare cost benchmark. So I expect we'll be continuing those conversations. I expect we'll be continuing to have conversations about greater price transparency for consumers, greater transparency about, pricing and costs and utilization for providers. So supportive of the direction of the task force, and just think that, it's not the end point.
Great.
Madam Chair, members of the committee, for the record, Cameron Smith with DCBS, and I would agree with Rep. Fahey. This would build on our experience with healthcare transformation over the last decade. And I think there's a lot of common sense and nervousness of kind of creating new bureaucracy or new reporting or new agencies to do this work. But we think this would truly build on a lot of that expertise and staffing and already structures that we have in place through the Health Policy Board in terms of some of the work that we've done on Medicaid and the CCO work, and that this would be that next logical Oregon step to broaden it, not just to focus on hospitals, but that broader health system. And just as chair of the task force, I want to thank our legislative members here, as well as Senator Steiner Hayward and Representative Noble, all of the volunteer task force members that were dedicated since the fall to get this recommendation, and then huge kudos to Cassie, Oliver, Danielle, and others with LPRO for getting a great report out.
Great. Questions? Thank you so much. And so if you could, would you be willing to talk about that either December, when you have a final draft, December or January?
Report's done, yeah.
Okay.
The report's done. Senator Byers can take the lead on the bill. That's what he told me yesterday.
Yeah, you'll be hearing about a bill. You'll hear a bill from us, Madam Chair.
All right. Thank you very much.
And I do want
to be quite clear, I've asked Mr. Dropplers to work with LC to draft the bill to implement the report.
Sounds good.
Okay. We need the report, Regional Health Equity Coalition in Oregon, Xenia Junker, Clarice Frietas, and Stick Crosby, if you'll come forward. And I'm sorry I mutilated your names, but you can correct me.
All right, here am I reading from my phone again. Well, good morning, Chair Moniz Anderson and Vice Chair, the board and committee members. Thank you very much for allowing us to come here and talk a little bit about what the Regional Health Equity Coalitions have been doing. My name is Clarice Amorim Freitas, and it's a hard last name. And I'm the coordinator of the Lean Benton Health Equity Alliance, a project of Willamette Neighborhood Housing Services. We are one of 4 regional health equity coalitions here in Oregon, and all of our coalitions are community-driven, and we use really different strategies to build on the strengths of local community to implement policy, system, and environmental changes in support of increased health equity for communities of color. Some of our work has started before our coalitions had financial support from the state. However, since 2011, when the Oregon Health Authority started funding our coalitions, we have been able to do more of our work and better serve our communities. Currently, there are state-funded coalitions serving the following Oregon counties: Lean, Benton, Hood River, Wasco, Multnomah, Washington, Clackamas, Jackson, and Josephine. There are also a couple new regional health equity coalitions being developed in Eastern Oregon and with the Confederated Tribes of Warm Springs. Collectively, we serve 57% of Oregon's total population, 57% of Oregon's Medicaid population, 53% of Oregon's communities of color, and 60% of Oregon's Latino communities. And in order to tell you why our work is meaningful for the community, I want to spend a little bit of time talking about the history of grassroots community engagement and leadership development, specifically in Lean and Benton counties, and then my colleagues will cover other areas. So our coalition is one of the oldest of its type, and it's been around for at least 10 years. And what started as a truly grassroots effort on the part of interested community members has really evolved into an organized effort across sectors. So currently we have some pretty big organizations that are members, including our Coordinated Care Organization, Samaritan Health Services, and Oregon State University Extension Services. And these powerful institutional players, they really share decision-making in the coalition with very small, nonprofit, often volunteer and grassroots organizations. Small PTAs, the NAACP, little nonprofits that have operational budgets of less than $50,000 a year. I list the background of these organizations as a way to show you how we are building cross-sectional partnerships between really unlikely partners working in different areas. And this is just one of the ways in which we have allowed all of these organizations to better serve our community. On a more personal note, I have been in this position as the coordinator for 2 years. And I'm an immigrant in the US, and when I was offered this job, I had been in Oregon for just over 4 years. And at that point, even though I had been pursuing a graduate degree and I had a lot of understanding about health promotion and health policy, even I didn't feel like I could, have a say in decision-making at our city and our council and in our county. Being part of the coalition has really allowed me to see some community leaders in the making in action. Some of our longest-standing members have become known community voices for health equity. And just over the last 2 years, I've seen people change the way they talk about how their organizations need to support healthy communities. I've seen coalition members take and thrive in positions at community advisory boards, schools, hospitals, and government. I've seen them, through intentional capacity building, work to improve their understanding and their ability to talk about really complicated issues like social justice, racial equity, and intergenerational trauma. And collectively, we have become a reference for local government and local organizations, and we can give them feedback in candid but honest ways, and holding local institutions accountable for their priorities. Just in the past few years, we have organized, trained, and support a really wide network of community advocates that have become a constant presence in city council and county commission meetings where decisions are made about housing, health, and education. And we helped pass a property maintenance code in the city of Corvallis to protect the needs of tenants. And we also helped pass a stronger tobacco retail license to protect vulnerable youth in our counties from predatory tobacco marketing practices. And I just want to say that this kind of authentic community engagement and leadership development doesn't really come easy, and it doesn't really come fast. And it takes years to get people who never felt like they belonged in decision-making areas to develop these skills and to harness the courage to actually talk. This is really invaluable work for our marginalized communities, and yet there are very few resources out there to support this kind of work. And we at the Lynn Benton Health Equity Alliance know that we wouldn't be able to do our work without the support of the Oregon Health Authority through the Office of Equity and Inclusion and the Health Promotion and Chronic Disease Prevention section. And we truly appreciate the opportunity to letting you know a little bit how meaningful that support has been for us over the last few years.
Good morning, Chair Moniz Anderson and committee members. My name is Stick Crosby, and I'm the Network and Health Equity Manager for All Care CCO, as well as a steering committee member of Southern Oregon Health Equity Coalition, or So Healthy for short. Our Regional Health Equity Coalition covers the district of Senator Alan DeBoer, and I want to thank you for your time today to discuss this. So Healthy currently covers Jackson and Josephine counties, and as you can see from our strategic priorities submitted yesterday, we'll be in Douglas County by 2019. As an administrator within a CCO that has membership in all three of these counties, All Care could not have come as far as we have in including all communities to have equal opportunity to live healthy and fulfilling lives without the help of the Regional Health Equity Coalition. So Healthy has become a true accountability method for the CCO within the community. By having a diverse coalition of backgrounds at the table and directly from the communities that we serve, we're able to hear the stories of true policy decisions being made that affect the lives of Southern Oregonians. Including representation from education, local providers, law enforcement, and all of the CCOs in the area, we're able to get community input directly to those that can affect change. To highlight a few of the projects that All Care has been able to strengthen by working in collaboration with So Healthy strategic plans, and I really want to echo this too. I heard from another speaker earlier today about culturally linguistic appropriate services, right, and making sure that the services we have are representing the community that we have. This, I think, really drives home that point. So Healthy's goal was to have 15 additional certified medical interpreters added each year within the area. In 2015, there was a listening session held with the Latino community, and overwhelmingly the ask was for there to be more interpreters in the region, and not only interpreters, but certified interpreters. All Care and So Healthy were able to license a curriculum from Bridging the Gap out of Seattle, and now this training is offered twice a year in Southern Oregon. There was 5 certified or qualified interpreters of 2 languages in the region in 2015. There is now 63 interpreters of 11 spoken or sign languages in our region. We're projected to have 83 by the end of 2018. Another piece that we were able to have a little bit of accountability on this too was then the groups that we're serving, right? These individuals weren't only becoming qualified interpreters, but then on top of that, there's another certification with the state to become certified. The only testing site for the oral test was in Portland, and we made that available in Southern Oregon. The next objective that I'd like to tie into is the ongoing training in equity, diversity, and inclusion. The goal was to have 100 individuals per year to participate in equity, diversity, and inclusion training sponsored by So Healthy, and the training to be directed at community institutions and organizations targeted 3 levels of influence: organizational leadership, management, and frontline staff. All Care was able to partner with So Healthy on this as part of our alternative payment models or value-based payment models. We added a health equity measure within that. To pass this measure, a provider office must have at least one certified or qualified medical interpreter on staff or have 70% of the location participate in cultural competency trainings. We have developed one 5-hour internal training with the help of So Healthy at All Care, and then an additional 8, which range from topics of cultural competency, social determinants of health, implicit bias, gender identity, and health literacy. To date, 1,400 individuals in Jackson or Josephine County have participated in these trainings. But then not only have we done these trainings from 2016 to 2018, we're able to measure a 2 percentage point increase of members reporting that their providers were discussing their care with them at a level that they could understand. Again, on top of where we continue to talk about these cultural linguistic appropriate services, right? Well, I would like to highlight another point of accountability that All Care has been able to have because of the Regional Health Equity Coalition, as we also have our dental health services that are then delegated. We weren't paying attention there, and so we started to focus on that and addressing class policies that we have with these delegates, along with language access policies. I also wanted to highlight the discussion of mental health that happened earlier today. The interpreter training that we have also dedicates 8 hours to specifically interpreting in a mental health setting. In closing, the Regional Health Equity Coalitions have been able to add another conduit for local communities to add that additional layer of local control, and again, that local accountability for our communities to tell us where we are acting wrong. These coalitions, well, not wrong, but where to improve. These coalitions are key to meeting the social determinants of health equity priorities in CCO 2.0 and invaluable to our marginalized communities. Thank you, Chair Monas-Anderson and the committee for your time.
Great.
Good morning, Chair Monas-Anderson, Vice Chair, committee members. My name is Dr. Xenia Junkier, and I'm Director of the Oregon Health Equity Alliance. I want to thank you for your time today. The Oregon Health Equity Alliance covers Washington, Multnomah, and Clackamas counties. As a resident of Multnomah County and someone that grew up in Washington County, it's an honor and privilege to work alongside my community members. My experience as a provider has been that patients are skeptical of our healthcare system due to a long history of inappropriate and harmful treatment at the hands of providers. The stories I've heard from patients are heartbreaking. Patients who are made to feel like they have no voice, no power, and no say in their own medical treatment. Patients who relay their symptoms only to be mocked, shamed, and/or told that they don't truly know what they are experiencing. Parents seeking, children seeking care, and parents who don't have access to care themselves. Folks who are categorically excluded, who require care to be able to not only care for their families, but also for their community members. I've seen patients struggling with suicidal ideations and chronic depression who cannot afford time off of work to care for themselves. And I hear from colleagues who treat children who have diseases that were once only seen in adults, who have no safe spaces for physical activity or access to affordable, healthy foods. I share this with you as a way to uplift the importance of reevaluating our systems of care, including how we provide care, how we offer resources, and how we understand health and health care. It's clear we have made great strides in Oregon. It is also clear we have much work to do. And to do this work, we must center the voices, experiences, and solutions of communities and individuals most impacted by health inequities. For us at the Oregon Health Equity Alliance, that means we transform the ways in which communities of color have engaged in the decisions that affect our everyday lives. We do this in part through advocacy on the local, regional, and state levels, and we do this through direct engagement as well. Community-powered change is one example of this work, born out of our work leading the Multnomah County Community Health Improvement Plan. Community-powered change is lifting community voices to build the future we want to see, defining health equity for ourselves, transforming the ways in which communities engage with institutions and organizations that create policy change towards more equitable health outcomes. It means creating healthy communities by dismantling racism at every turn and creating a space where health equity is valued and practiced by everyone. We leveraged these values when we fought for the Reproductive Health Equity Act in 2017, and the same year OHE was integral in the passage of Cover All Kids, or OHP Covers Me. Engaging constituents, community members most impacted, and allies to ensure that no child in Oregon has to miss school because of an illness they were unable to seek care for. This is a prime example of how healthcare access impacts more than just health, and why it's so important for the Regional Health Equity Coalitions to work from a social determinants of health framework. It is a reminder we still have thousands of adults in our community who cannot access care due to restrictions based on country of origin. And even for communities who have coverage, lack of representation of providers who reflect their communities they are serving and providers who provide culturally responsive and linguistically responsive care continues to keep us from equitable health outcomes. In the coming year, OHE is continuing to work to mitigate and address social determinants of health. As part of public health modernization efforts focused on communicable diseases like hepatitis A and latent TB, we will also once again be engaging our communities, prioritizing youth in the creation of tobacco use policies that come from communities who face shortened life expectancies and chronic health concerns due to the use of tobacco and alcohol. OHE will engage in work to ensure communities understand the disastrous effects of opioids on our communities and identify community-led solutions to address this public health emergency. And finally, we've been following CCO 2.0 closely, excited about the opportunities and critical of how community voice was and will be used to ensure policy options have the greatest impact, especially for communities of color who still face glaring health inequities. We wouldn't be able to do this work without the support of the Oregon Health Authority through the Office of Equity Inclusion and the Health Promotion Chronic Disease Prevention Program. Their belief in OHE and the other regional health equity coalitions to engage in work that is driven by community members themselves has allowed for all of the amazing work you've heard about today. I don't like to talk about our work in terms of return on investment, as it seems disrespectful to the people we serve, who deserve our work and our support no matter what the return is. However, to make this point, I will use that language, that with all the millions, perhaps billions of dollars spent on health, education, transportation, social services, et cetera, that just over $1 million shared across the 4 regional health equity coalitions and 2 capacity building sites clearly results in a very high return on investment. Again, I thank you for your time today. I know that it's limited and I appreciate you hearing from us. I'm happy to provide you with any additional information you need, and we want to work alongside you. I would welcome you to our office, to any events that we're hosting. We want to ensure that we are bringing to the table voices of Oregonians who aren't able to make it into this room today. This model is innovative and has opportunities to be replicated across the state. Let's continue to lead the country not only in healthcare access, but also in moving the dial on health disparities and creating conditions for the best Oregon possible. Thank you.
Great. I'm so glad that you were able to come and share. We haven't heard from this group before, and so I thought it was important to do that. Questions?
Just a comment. I really appreciate the hard work that you and all of your colleagues are putting into this. It is really important that every Oregonian have access to affordable, high-quality health care that meets them where they are and addresses who they are as a whole person. And that's what the work you're doing is trying to accomplish, and I really appreciate it.
Thank you.
Thank you very much.
Yeah, thank you.
And our final topic on the agenda is prescription drug initiatives in other states. Jane Horvath, who's a health policy analyst.
Does that work? Yeah. So good morning, and thank you so much for the invitation to come and talk with you here today, Madam Chairwoman Anderson and members of the committee, and I thank you for your patience. I know I'm batting clean up here, so I will try to be as concise as possible, and I was just hoping for more of a conversation, too. I really don't have a very long presentation. Do you have my slides?
Slides? And please say your name for the record.
Sure. My name is Jane Horvath, and I am a healthcare financing policy consultant. I have spent a good chunk of my long career working with states over the years on a variety of issues in Medicaid and public health and more recently now pharmaceutical cost containment policy. And importantly about my career myself is that I spent 14 years working in and with the biopharmaceutical industry. So, and that was most recently what I've done before I've started this consulting work. So, okay, we can go to the first slide, or second slide, I'm sorry. So I wanted to just reprise for you briefly what the activity that we've seen in state legislatures this year, the 2018 session. There's only a few states that have their legislators still in session. So I think that this is probably a pretty good summation of where we are. So in terms of transparency, we have 3 new laws in 3 states, of course, Oregon being one of them. And then Maine and Vermont are the other 2. Maine is a study, and Vermont was basically improving a transparency bill that they had enacted several years ago and strengthening it. What I found interesting this year was drug substitution laws in 5 states. And I expect this, I'll talk about it in a minute, but a trend going forward, because the concept is relatively new on the legislative agenda, and these bills have passed pretty much in the same year that they have been introduced, which, as I'm sure you know, is not always typical. So importation, this is importing prescription drugs from Canada specifically. Vermont passed a law this year. And again, it was a first round. It was introduced this year and enacted this year. And now Vermont is in the process of implementing that law. And then Medicaid, most
and
of
I know we are, there are some people going to present or bring forth legislation regarding that.
Yeah,
yes.
I do know that. And then in Medicaid, we had a couple laws, but also a lot of administrative activity going on, very high-level activity. So some of what we've seen in states is aligning their Medicaid managed care organizations with their fee-for-service formularies, so creating one unified formulary to, I think that's mostly aimed at negotiating better supplemental rebates for the program. And, there's lots of pros and cons to that. And then state of Ohio, famously this year in Medicaid, sort of negated their contracts with their Medicaid PBM and is sort of starting over and requiring much greater transparency and moving away from the rebate model in terms of contracting with pharmacy benefit managers. New York has a Medicaid budget cap that they have created this year, and the purpose is, well, I can get into more of the details, but it's a budget cap, and it's an analysis of the prescription drugs that are actually driving in any particular year or quarter the drugs that are pushing the program over their cap, if that were to happen, and then looking specifically at those drugs with a potential value assessment on those drugs that are driving the program over the cap in any particular quarter. We have a state, it's Colorado, doing a study looking at physician-administered drugs, but trying to move their payment system to actually trying to pay just for the acquisition cost of those products for the physicians. And then we have some states trying to create sort of all-payer unified formularies. So it would be state employees, large hospital systems, Medicaid. I will say that it's small states that are looking to do that. And then PBMs, this was obviously probably, I would say, the hottest topic this year among state legislatures. And we had 31 new laws in 23 states, and they ran the gamut. I mean, some were very comprehensive laws, some were just gag clauses. In general, they were aimed at changing the business model of the pharmaceutical benefit management industry in those states.
And we have legislation pending here also on that.
Yes. The next slide. So looking ahead to next year, based on what I've seen in the last 2 years across the states, I think there's going to be efforts still at manufacturer transparency that sort of really slowed down this year, surprisingly. In 2017, we had several states enact very comprehensive laws, sort of seminal laws, if you will. A lot of states have been looking at Nevada's law and California's law. Parts of 4005, the Oregon law, were based on SB 17 in California as well. But those states were facing lawsuits, and I think that really slowed things down on the manufacturer transparency front, with the exception of Oregon and a few other states. But I think next year we'll probably see more of this activity, and I think states are going to go back and strengthen some of their laws. I think states are going to start looking at not reinventing the wheel. California's data, and I believe Oregon's, is going to be public. There's going to be a certain amount of the data available. California is creating a database that will hopefully be queried. And so states can sort of reduce their fiscal notes by looking at the work and supporting the work in California and Oregon on just data collection for whatever purposes that they want to put it to. I think we're going to see more of this drug substitution, and just a bit more detail on that. That is either allowing or requiring a pharmacist at the point of service to substitute a therapeutic alternate, the bills vary, therapeutic alternate or a biosimilar, which is the follow-on product, the generic, if you will, of an expensive biologic product. And so I do expect, because of the sort of rate of success of those bills, that we'll be seeing more of them next year. I think we're going to see more action on importation too. 9 states actually introduced the bill last year. It passed in 1 state, and it did move forward in several states. It had like more traction than I had expected it to have. So I do expect it to come around next year for a variety of reasons. And then the Drug Affordability Board, so this was introduced in 3 states last year, and it actually moved quite far in the Maryland legislature. But it was introduced in New Jersey, Minnesota, and Pennsylvania, I believe. The Pennsylvania was sort of a bit of a one-off on the actual model, but it was introduced. So I think there's going to be more activity around that. In Medicaid, I expect to see a lot more value-based purchasing and the drug list alignment in some way, shape, or form in the state. And PBMs, I think states are probably going to go back and try to strengthen the ones that didn't pass comprehensive PBM regulatory bills are going to probably go back and try to do a little bit more based on the scope of what we saw happening across the states this year. So if we could... Great. So, I think that in my view, sort of states were getting their feet wet with looking at transparency issues. Sort of transparency allows you to see really what's going on and get a grip on a highly complex industry, a very broad industry with lots and lots of players and lots of money. And now I think states are looking to move beyond transparency to try to find ways to move the needle and constrain cost growth in pharmacy benefits. And in Medicaid, some of these things would include formulary alignment. States can eliminate not without controversy, of course, but eliminate the dispense as written laws. Some states still have those permissive policies in the Medicaid program. And you could do it just for some fee-for-service classes as opposed to all of them. And then there's dose optimization policies, too. We're seeing that in the private sector, and Medicaid's starting to look at that as well. And that's something else that could have an impact on cost. For sort of the state employee and corrections market segment, if you will, I think states can look at and will be looking at joint contracting. And a new idea that I'm just starting to explore is sort of recouping for state employees or prisons price increases as they come along. That's sort of the similar mechanism to what Medicaid has in federal law. When prices increase, the rebate to Medicaid increases so that Medicaid actually isn't paying the increase on net. And then commercial market, large state programs, you could look at, or a state could look at the Drug Affordability Board, as I think more states are going to do, but that is actually designed to actually constrain prescription drug spending for certain drugs. Maryland had passed the anti-price gouging bill. The Fourth Circuit has declared it unconstitutional, but I think there are ways of working with the Maryland model to address the concerns that the Fourth Circuit had with the Maryland price gouging bill. There are ways of constructing a law that would better meet the criteria that the Fourth Circuit set out. Importation is certainly a way to change the cost trajectory in a state. And then multi-state purchasing is something I know other states are starting to look at, and basically built on the Oregon model, basically the Oregon-Washington joint purchasing, joint discount model. So there are other states looking at that, and I think it would probably be wise to look at building out what Oregon and Washington have built as opposed to recreating a bunch of different new wheels around the country. So just to drill down briefly on some of the system-wide options that a state would have to look at all the markets in the state and all the being able to assist all the residents of the state. I think that would be a prescription drug affordability board. And basically what this is setting reimbursement rates, payment rates. It's basically an all-payer system for certain prescription drugs that create financial, systemic health system financing challenges. So, and it's very similar in a way to the Public Utility or Public Service Commission boards that every state already has. And the model that I worked on to develop with NASHB, it follows that in that it's a very small number of commissioners supported by an expert staff collecting a lot of public input, a lot of proprietary information as well to help make informed decisions. And it basically, the board adds weight and strength to what every payer does for almost every drug in every state, public or private. And importantly, it gets the benefit down to the consumer at the point of service, unlike most other things that you can think about in a very complex supply and delivery chain of drugs. And it protects the pharmacists.
And you said Maryland has this?
Maryland introduced the bill last year. It got debated all the way through the House, a vote on the House floor, and got out of Senate committee last year. But it didn't make it to the end before the legislature adjourned. Government programs, Medicaid and state employees programs already basically do this. I mean, it's not an all-payer system, but they set up the rates that they're going to pay and reimburse for drugs. So, I mean, basically you have government agencies or entities already doing this for prescription drugs. So in terms of other sort of system-wide projects that a state will probably undertake or could undertake, could we just roll on to the next one? Great. So anti-price gouging, as I said before, I think that there are ways of addressing the Fourth Circuit concerns, and we can talk about that in detail if you wanted. And importation from Canada, obviously, I believe strongly that this can change the cost trajectory in a state. And I think what most people don't really realize is that 40% of our drugs already in the United States are imported from outside the country, and 80% of the raw ingredient used for U.S. manufacturing of drugs is imported with, obviously FDA approval and oversight for the U.S. market today. And the supply chain for the pharmaceutical industry is very global now, and it's very safe. And so that's what an importation, a state-administered importation program would build on, that existing safe global supply and manufacturing system. And then again, multi-state purchasing, I mentioned before. And I was remiss, I apologize, I did not put on this slide something that Louisiana is doing that I think is very interesting for states. Now, Louisiana is just doing it now for corrections and for Medicaid, but the model, I believe, is expandable. You can size this model, but it's a form of discount volume purchasing, and they're looking particularly at hepatitis C products because the target population in need of treatment is the state simply can't afford it. And so to sort of ramp up and get everybody treatment who should be having treatment, the state is going to hopefully negotiate with manufacturers, and they've had some conversations with manufacturers at this point, exploring the model, where they would almost prepay or bulk purchase for a certain quantity and an anticipated quantity of what they would need in a year. But if they use more, like up to a certain limit, there's an add-on quantity of Hep C product that they could get if they're actually getting more people into treatment than they originally estimated. That's not an unlimited supply, but it is sort of like an extra supply or reserve supply. I tend to think of it as like when you pay for a dozen donuts, you get the 13th. You don't get 20, but you get the 13th for the same price as 12. That's how I can sort of visualize the model that Louisiana is talking about. And from the manufacturer perspective, they have, a known sales amount, like it's an established and healthy quantity of product to actually be able to engage in this kind of negotiation. And then just final thoughts before, if you have any questions, is people don't tend to think of their state government in this way, but in the states that I've worked at, I've just run these very rough numbers. They're not the final numbers at all. But like in Oregon, it looks to me like state residents, 36% of state residents are supported by Oregon taxpayer for the pharmacy benefit. And it's kind of surprising when you think about it that way. In other states that I've looked at too, it's anywhere from 27 to 31%. And again, this is just quick math. It can be far more refined calculation than I've done, but it's worth thinking about. It's worth states considering. And that's it.
Wonderful. It's nice to have all of this, because sometimes when bills come before me, I'm not aware that we're not the first state to be dealing with this. It's nice to know what other states are doing. Are there any questions?
Madam Chair.
Yes, please.
As you know, we passed House Bill 4005 out of this body in 2018, which, in addition to setting up our share of price transparency on the pharmaceutical manufacturer side, also established the task force on fair pricing of prescription drugs. Cassie has been inordinately effective in staffing that, along with Oliver and several other people, and we have made, I think, really good progress in that arena, thanks in part to Ms. Horvath and many other people who've come to the table to talk with us about a range of options. I'm very grateful to my colleagues, Senator Linthicum and Representative Alonso Leon and Representative Noble, for their hard work on the task force, and I think we're going to come out with some really good proposals from that task force that will help us move and will incorporate many, if not all, but many of the suggestions and options that Ms. Horvath just outlined to us. So you'll be hearing more about that in the not too distant future.
Awesome. All right. Thank you very much for coming. I appreciate your time. And is there anything else I need to convey? All right. You know that the deadline for submitting LCs is Friday. So with that, we're adjourned.
There you go.